The heart monitor flatlined. Doctors scrambled, nurses froze, and the decorated war hero lying in that bed grabbed the nearest IV pole and hurled it at the wall, screaming for everyone to get out. Everyone obeyed, except her. The quiet woman in scrubs who walked back through that door wasn't what she looked like. She wasn't soft. She wasn't afraid. And she was not, under any definition of the word, just a nurse. But no one in that hospital knew that yet. And the dying colonel who'd spent 30 seconds insulting her had no idea he was about to meet someone who had once carried his soldiers home from the dead. If this story already has you hooked, follow my channel so you don't miss what happens next. Hit like and drop a comment telling me what city you're watching from. I want to see exactly how far this story travels. The morning started the way most mornings did at Callaway Veterans Medical Center, with the smell of floor wax, the low hum of the ventilation system, and someone in the East Wing yelling about something that hadn't gone the way they wanted. Nora Voss had learned, in her 6 years working the fourth floor, to identify the type of yelling before she even rounded the corner. There was the frustrated kind, was patients who'd been waiting too long or couldn't get the call light to work. There was the confused kind, men and women whose minds had started to drift, who sometimes woke up not knowing where they were or what decade it was. And then there was the other kind, the kind that came from somewhere older and more dangerous than frustration or confusion. The kind that had weight behind it, command. That was the kind echoing down the hallway right now. She picked up her pace. Room 412 had been flagged since the admission the previous afternoon. Colonel Raymond Holt, retired, decorated, 71 years old, had been brought in by ambulance from his home in Denton Falls, Colorado, after his neighbor found him unresponsive on the kitchen floor. Sepsis, the ER attending had documented. Possible early-stage pneumonia compounding it. He'd been stable enough overnight, but his blood cultures were still pending, and his fever hadn't broken. Nora stopped just outside the door when she heard something shatter. Then a voice, rough, with the kind of authority that had clearly never been questioned and didn't intend to start now. "I told you to get out. All of you. I don't need a pack of civilians running around me like I'm some kind of museum exhibit." She pushed the door open. The scene inside was not technically dangerous, but it was close. A water pitcher lay on its side near the window, a spreading puddle darkening the floor tile. Raymond Holt was sitting up in bed, which he absolutely should not have been doing, with his IV line pulled taut because he'd yanked his arm back so hard the tubing had gone nearly straight. His face was flushed, his hospital gown half off one shoulder, and he was pointing at the cluster of staff near the door like he was directing a firing line. 2 nurses Nora recognized from the day shift were already backing out. The patient care tech had his back flat against the wall, tray in hand, looking like he was trying to remember whether he'd chosen the right career. The attending, Dr. Marcus Webb, a solid physician, not particularly confrontational, stood in the center of the room with his arms at his sides, doing the careful, measured thing that experienced doctors learn to do when a patient is escalating, nothing that could make it worse. "Colonel Holt," Webb said, "I understand you're uncomfortable, but your infection levels—" "I know what infection levels are, son. I've seen men die of infections in conditions that would make your stomach turn." Holt turned his glare toward the door and caught Nora coming through it. "And who the hell is this?" "My name's Nora Voss." She didn't slow down, didn't look at Webb for permission or at the other nurses for backup. She walked to the far side of the bed, set her tablet on the rolling stand, and checked the IV insertion site on his forearm with the practiced efficiency of someone who had triaged people under considerably worse conditions than this. "I'm your nurse for this shift." "I didn't ask for a new nurse." "I know." She straightened the IV tubing without pulling on it. "You threw a water pitcher. Administration thought maybe a change would help." He stared at her. "Are you being smart with me?" "I'm being accurate with you." She looked at his face, really looked, the way she'd trained herself to, reading the things underneath the anger. The fever was obvious. His eyes were too bright, his skin color wrong in the way that happened when a body was working twice as hard as it should. He was in pain, and probably had been for longer than he'd admitted before calling anyone. "How long was the fever before your neighbor found you?" A pause. Not the angry kind, the kind where someone was recalibrating. 2 days, maybe. "I thought it was a cold." "Your temperature right now is 103.4. Your white count from last night's labs was elevated enough that we're treating empirically while we wait for the cultures. She kept her voice flat and informational, not sympathetic. He didn't want sympathy. She could see that from across the room. The antibiotics are working through your line right now. You pulled your arm, which means I need to check the site before we have an infiltration problem. Another silence. Webb, behind her, seemed to have decided the situation had been handed off and was willing to let it stay that way. Holt looked at her hand on his arm, then at her face. "You're not scared of me," he said. Not like it was a compliment, more like he was noting something unexpected, the way you'd note a weather pattern that didn't fit the forecast. "No, sir." "Why not?" Nora peeled back the tape at the IV site, examined the surrounding skin. Intact, no swelling, the line was fine. And replaced the tape with fresh strips from the supply on the stand. "Because you're not trying to hurt anyone. You're just angry and sick, and you don't like feeling helpless." She straightened. "Most people in your position feel exactly the same way." He didn't answer immediately. The flesh in his face had shifted slightly. Still there, still feverish. But some of the rigidity in his jaw had changed. "I want a military medic," he said. "Someone who knows what real—" "I'll send Dr. Webb back in when you're ready to discuss your care plan," she said, already turning. "In the meantime, don't pull the line again. If it infiltrates, I have to restart it, and that's a worse morning for both of us." She walked out before he could finish the sentence. Webb caught up with her at the nurse's station. "That was—" he started. "He needs a repeat CBC in 4 hours, and someone should check in every 90 minutes, whether he wants them to or not." She pulled up the chart on the workstation. "His pressure's been trending lower since admission. Has cardiology been consulted?" "It's on the list." "Move it up." Webb looked at her for a moment with the expression doctors sometimes got, the one that sat between irritated and impressed, and hadn't decided which way to fall. He was a decent doctor, not the kind who needed his ego managed every 5 minutes, which made him easier to work with than most. He's going to keep being difficult. Probably. She didn't look up from the chart. He's allowed to be difficult. He just can't keep staff from doing their jobs. He's requesting a male nurse. That's not a clinical accommodation. I know. I'm just telling you what he said. She pulled up the vitals trend and frowned at the blood pressure column. 3 readings in the last 12 hours, each one slightly lower than the last. Not critical yet, trending towards something she didn't want to ignore. "I'll be back in his room in 40 minutes. If he throws anything else, we document it and loop in patient advocacy. But I'm not coming off his case." Webb nodded once, then walked away. Nora sat with the chart for a moment after he left, reading backwards through the admission notes. Raymond Holt, retired. 26 years of active service, multiple deployments, a list of commendations that took up 3 lines in the intake form because whoever had typed it had run out of space. He'd been awarded the Silver Star at some point in the early 2000s, though the details weren't in the medical record, just the reference. The intake nurse had noted next of kin as none listed, emergency contact as a retired master sergeant named Dale Pruitt, relationship listed as friend, no family. A friend from the military is the only person to call if something went wrong. She'd seen that pattern before, more than once. She finished her note, stood up, and went to check on her other patients. Bad. The floor had 6 of them that morning, not counting Holt. A post-surgical knee replacement in 408 who was doing well, and mostly wanted to talk about his granddaughter's soccer tournament. A 64-year-old woman in 410 recovering from a cardiac event, stable but anxious, who needed more reassurance than clinical intervention at this point. 2 beds in 415. Brothers, both admitted the same night for different reasons, which the family found either funny or devastating depending on which hour you caught them. And the man in 411, Mr. Darrell Oakes, who had been on the floor for 11 days now, and who Nora checked on with a particular kind of attention because he reminded her of no one she would name out loud. She was in the middle of changing a dressing on Oakes's arm when her radio crackled. "Voss, 412's alarming. Can you get eyes?" She finished the tape, told Oakes she'd be back, and walked out. The alarm in Holt's room was the IV pump. He'd reached over and, in what she could only assume was a deliberate act of protest, partially kinked the line by folding his arm. The pump had responded by screaming at him. He was sitting with his arms crossed, staring at the ceiling, apparently prepared to wait it out. Nora walked in, unkicked the line, silenced the alarm. "You did that on purpose," she said. "Prove it." "I don't need to prove it. I just need to unkink it," which I did. She checked the pump settings and reset the rate. "Are you trying to make my morning harder, or is this something else?" He looked at her sideways. "You don't rattle." "Not usually." "Why?" She didn't answer immediately. There was a chair beside the bed, not the comfortable visitor kind, just the standard institutional plastic, and she pulled it closer and sat down. Not because she had time to sit. She had 4 other patients and a consult request waiting, but something in the way he'd asked the question wasn't combative. It was closer to genuine, which was different, and she'd learned the difference mattered. "Because I've been in rooms where rattling would have gotten someone killed," she said. "After that, this is manageable." He turned his head and looked at her directly for the first time. Not the performative glare he'd been using, actually looked at her. "Where?" "That's not a conversation for right now." "Why not?" "Because right now, we need to talk about why your blood pressure has dropped 4 points in the last 3 readings and whether cardiology has seen you yet." She stood up. "Dr. Webb should have the consult in by noon. Until then, I need you to leave the line alone." He was quiet for a moment. The particular quality of the quiet had shifted again. There was something turning over behind his eyes. She'd seen it before, in people who were reassessing. "You said rattling would have gotten someone killed," he said. "Yes." "That's not something you say about nursing school." She looked at him. "No, it's not." She left before he could ask the follow-up. The cardiology consult came back within the hour. Dr. Priya Shenkar, who ran a tight shop and did not appreciate having her schedule disrupted, had nonetheless come in person rather than sending a resident, which told Nora the referral note had communicated the concern correctly. Shenkar reviewed the pressure trend, listened to his heart, ordered an echocardiogram, and was back out the door in 14 minutes. "Septic cardiomyopathy," she said to Nora in the hallway. "Possible. We'll know more after the echo. Keep him monitored, and if that pressure drops another 5 points, we're looking at a transfer to the ICU." "Understood." "What's his affect?" "Hostile." Shenkar raised an eyebrow. "Toward staff?" "He's managing it. He hasn't actually done anything actionable. He's frustrated, he's in pain, and he has a significant amount of difficulty accepting help." Classic presentation. Shenkar already had her phone out. "Keep me posted. And Nora, good catch on the trend." Nora nodded and went back to the station. She was updating the care notes when the charge nurse, Deborah Falk, appeared beside her. Deborah was 53, experienced, and possessed of the particular brand of institutional knowledge that came from spending 20 years in a place. She knew which supply orders got lost, which physicians returned calls and which ones didn't, and which patient complaints were worth escalating and which ones needed to be absorbed. She also had a habit of saying difficult things very carefully. "There's been a complaint," Deborah said, keeping her voice low. Nora didn't look up. "From 412. From 412 and from Supervisor Grant." A pause. "He says you were dismissive to the colonel this morning, that you cut him off mid-sentence and left the room." "I had 4 other patients and he was medically stable enough that the conversation could wait." "Grant's saying the colonel specifically requested someone with military background. He wants to use that as grounds to reassign you." Now Nora looked up. "Military background isn't a clinical credential." "I know that." "And he's the attending's patient. Reassignment is a clinical decision." "I know that too." Deborah's expression said she was delivering information she did not personally endorse. "Grant has some administrative latitude on staffing. He's not wrong that he can make a recommendation." "Then he can make a recommendation and Dr. Webb can decline it." "Webb might not decline it if Grant pressures him." Nora set down her pen. She knew Gerald Grant, had worked under him for 3 years. He was not a bad administrator in the broad sense. He kept the floor running, he managed scheduling with competence, and he didn't cut corners on supply orders. But he had a particular response to difficult patients that Nora had noticed early and never stopped noticing. He prioritized the complaint over the care. A loud patient generated paperwork. Paperwork generated meetings. Meetings generated the kind of visibility Grant found uncomfortable. His instinct, every time, was to rearrange the furniture until the noise stopped. She had been rearranged before. She was tired of it. "If Grant comes to me directly," she said, "I'll address it then." Deborah nodded slowly. "He's already asked to see you at noon." Grant's office was on the third floor, removed enough from patient care that it had a window with an actual view, the parking structure and a slice of blue Colorado sky above it. He was behind his desk when she came in, jacket on, reading glasses pushed up on his forehead the way he did when he was preparing to be serious. "Nora." He gestured to the chair across from him. "Close the door." She closed it and sat. "I'll be direct," he said. "Colonel Holt has made 3 separate complaints since admission. Nursing staff, the attending, and now the general patient experience line, which means it's going to end up in a report. He's a septic patient with a dropping pressure trend who is scared and doesn't have anyone with him," she said. "Difficult patients are part of the work." "Difficult patients are, yes. But Colonel Holt is also a decorated veteran with connections to the hospital's board-level donor committee." Grant let that sit for a moment. "He has asked specifically for a nurse with military medical experience. We have 2 staff members on the roster with prior service backgrounds. I'd like to move one of them onto his case." "And off it, you mean me?" "Yes." She looked at him evenly. "He's medically complex. Cardiology's involved, the culture results are still pending, and there's a pressure trend that may push him to the ICU by end of shift. Handing off a patient in that window creates gaps. The handoff can be thorough. Thorough doesn't replace continuity, not with this presentation." Grant folded his hands on the desk. "Nora, I understand you feel strongly about this, and I'm not making a judgment about your clinical ability, but this is a patient satisfaction issue, and we have a responsibility. Patient satisfaction doesn't supersede patient safety." "No one said it does." "It's what you're describing." A pause. Grant's expression tightened at the edges in the way it did when he felt he was losing the logic of a conversation. "I'm telling you that I'd like to make this change, and I'm asking for your cooperation. And I'm telling you that I think it's the wrong call clinically, and I want that on record. It will be documented." "Good." She stood up. "Nora." His voice had changed. Not softer exactly, but more careful. "He's a hard case. Not everyone can manage a patient like this. There's no shame in—" "I'm not having trouble managing him," she said. "He's having trouble being sick. Those are different problems." She left. By 2 in the afternoon, 3 things had happened that changed the shape of the day. First, Raymond Holt's blood pressure dropped. Not catastrophically, not yet, but enough. The echo results had come back and Shenkar had been right. The infection had gotten into the cardiac muscle, a septic process that was doing more damage than the admission notes had suggested. The ICU was notified. Transfer was likely within the hour unless they could stabilize him. Second, Grant had sent an email, copied to Webb and the night shift charge nurse, formally documenting his recommendation to reassign Nora from the case. It was phrased carefully. Concerns about patient rapport, best interests, smooth transition, but the meaning was plain enough. Third, Nora had walked into room 412 to tell Raymond Holt they were likely transferring him to the ICU and found him not in the bed, but sitting upright in the chair beside it, both feet on the floor, hospital gown hanging open in the back, trying to reach the window. "What are you doing?" she said, and it wasn't a question. "I can't." He stopped. His voice had changed from the morning, not quieter exactly, but different, less manufactured. "I can't breathe well lying down." She got him back into the bed. Not easily, because he was 2 inches taller than her and significantly heavier, and he didn't go without some resistance, but she'd moved uncooperative people before. She reclined the head of the bed to 45 degrees, reassessed his oxygen saturation, added 2 liters by nasal cannula, and called the ICU charge to update the timeline. When she finished the call, he was watching her. "They're moving me," he said. "Yes, within the hour probably." "What's wrong with my heart?" She sat down on the edge of the chair. Not the whole way. She'd need to stand again in a minute, but enough that she wasn't talking down at him. "The infection has affected the heart muscle's ability to pump efficiently. It's called septic cardiomyopathy. It's treatable, but it means you need closer monitoring than we can provide up here." He absorbed that. "Is it bad?" "It's serious." "That's not what I asked." She met his eyes. It could get worse before it gets better. The ICU team is good. Dr. Shenkar will stay involved. He nodded slowly, then, "They're taking you off my case." She didn't answer right away. "I heard Falk on the phone," he said, "and that administrator, Grant, came by while you were gone. Told me there'd be a transition." "That's an administrative decision," she said carefully. "It's a stupid one." He said it flatly, without inflection, the way he'd probably said 100 things over his career that he meant completely. "You're the only one on this floor who hasn't treated me like I'm either fragile or a problem to be managed." "You have been a problem to be managed," she said. "You threw a water pitcher." Something moved across his face. It took her a second to place it because it was unexpected. It was close to humor. "Fair point," he said. She stood up, checked his oxygen number on the wall unit, still low but holding. "I'll brief whoever takes over. The handoff will be complete." "Voss?" She looked at him. His expression had gone back to something harder to read. Not the hostile performance from the morning, not the reluctant openness of the last hour. Something in between. Something old and practiced and not entirely comfortable with what it was about to do. "That administrator is going to pull you off this case because I complained," he said. "And I want you to know I didn't ask for that." "I know." "I was wrong to—" He stopped, started again. "I was wrong this morning about what I said." She looked at him for a moment. 6 years on this floor. 100 patients like this one in different ways, different names, different specific wounds, both visible and not. She'd stopped needing the apology a long time ago. What she needed, and had never quite stopped needing, was for the work to matter, for the decision she made in that room to count. "Get some rest before the transfer," she said. "The ICU team will come up for a handoff walkthrough in about 40 minutes. She was almost at the door when the monitor alarm went off. Not the IV pump this time, not the call light, the cardiac monitor. She turned back around and Raymond Holt was slumped sideways in the bed, eyes half closed, the color draining from his face with the sudden efficiency of a body that had decided it was done compensating. She hit the call button on the wall and was already at his side, 2 fingers at his carotid, the other hand reaching for the crash cart key on her badge. His pulse was there, weak, irregular, and going somewhere wrong fast. "I need a team in 412 right now," she said into the radio, and her voice was completely level. "Pressure's dropped. I need the attending and the ICU resident. Do not send a tech. I need physicians." She pulled the crash cart closer with one hand and kept her fingers on his pulse with the other, and did not think about the administrator's email or the formal reassignment recommendation or the politics of the 4th floor or anything except the 68 beats per minute that had just become 52 and was still falling. Raymond Holt's eyes opened, barely. "Voss," he said. His voice was almost nothing. "I'm here," she said. "Don't talk. Don't let them—" A pause, a breath that cost him something. "Don't let them send you away." The door burst open behind her. Webb and the ICU resident came through together, and the room filled with the controlled urgency of people who knew exactly what they were doing. Nora Voss did not step back. She held her position at the bedside and told them everything she knew. The pressure trend, the echo results, the timeline, the medications on board, in the clipped, precise shorthand of someone who had given situation reports before, in conditions far less clean than this. Neither doctor interrupted her. Neither of them asked her to move. And Raymond Holt, fading and frightened and trying not to show either, kept his eyes on her face the entire time. The ICU was colder than the 4th floor. Not dramatically, a few degrees at most, but Nora had always noticed it, the way the temperature dropped as you crossed through those double doors, as if the building itself understood that the margin for error had gotten smaller. Raymond Holt had been transferred up within 20 minutes of the episode. She'd walked alongside the gurney until the elevator doors closed, then stood in the hallway for a moment doing nothing, which was not something she did often or comfortably. Webb found her there. "Good call on the pressure trend," he said. "If that had happened during a shift change—" It didn't. She pulled up the chart on her tablet, already switching gears. She had 5 other patients and an afternoon that was now running 40 minutes behind. "Has Grant been notified about the transfer?" "He'll see it in the system." "I mean about the circumstances. The drop happened during the reassignment window. If he'd been handed off when Grant wanted—" "I know what you're saying, Nora." "Good. She didn't say anything else. She didn't need to. Webb stood there a moment longer than necessary, which usually meant he was working up to something. Grant's going to argue the transfer was coincidental, that it would have happened regardless of who was on the case. He's welcome to argue that. He has the board donor angle. That carries weight with administration. Then administration has a problem. She walked away before the conversation could become something she'd have to manage on top of everything else. The afternoon ran the way afternoons ran when a morning had already taken too much out of you, constantly, without pause, with the particular exhaustion that came not from the physical work, but from holding everything in your head simultaneously. She checked on her remaining patients, caught up on charting, fielded a question from the night shift about a medication order that had been entered with a decimal point in the wrong place, and ate half a granola bar standing at the medication cart because it was that or nothing. At 4:15, her phone buzzed with an internal message from Deborah Falk. Grant is formally submitting the reassignment request. It's going to HR. He's citing the complaint documentation and the failure to transfer rapport language. I thought you should know before end of shift. She read it twice. Set the phone face down on the cart. Failure to transfer rapport. She had a pretty clear idea of what that phrase was doing in an HR document. It was doing the work that she's difficult or she doesn't listen, couldn't do anymore. Not since the hospital had gotten very careful, after a lawsuit 3 years ago, about the language used in staffing decisions. Failure to transfer rapport was clean, clinical sounding. Impossible to disprove and equally impossible to defend against because rapport was subjective and subjectivity was, in the hands of someone like Grant, a remarkably flexible tool. She picked the phone back up and typed, "Received, thank you." Then she went back to work. She didn't go home at the end of her shift. This was not unusual for Nora. There had been stretches of her life, years of it, when going home meant going somewhere empty, and the hospital was at least full of noise and purpose. But tonight, the reason was specific. She stopped at the ICU on her way out, badge still on, still in her scrubs, and asked the unit clerk if she could check on a patient. Holt Raymond, admitted this afternoon. The clerk checked her screen. He's in Bay 6, family only after 8. I'm his nurse of record until the paperwork goes through. I need to review the handoff notes. It wasn't entirely untrue. Bay 6 was at the far end of the unit, partially curtained. She could hear the equipment before she reached it, the rhythmic certainty of the monitors, the soft mechanical sigh of the supplemental oxygen. He was awake when she pushed the curtain aside, which surprised her. It was past 8. He looked exhausted in the way people looked when their bodies were working too hard to let them sleep. "You came back," he said. "I'm checking the handoff documentation." "You're checking on me." She didn't confirm it. She looked at the monitor readout over his head. Pressure was better. Not good, but better. The rhythm had steadied. Whatever they'd given him in the first 2 hours had pulled him back from the edge he'd been standing on when the alarm went off. "Your pressure's improved," she said. "They told me." He watched her read the monitor the way she'd probably watched hundreds of people look at something with the particular focus of someone who understood what they were seeing. "Sit down." "I'm not staying." 5 minutes. She looked at the chair, looked at the time, sat down. For a moment, neither of them said anything. The ICU had its own acoustics, quieter than the floor in some ways, louder in others, the persistent background of machines doing things that bodies should be doing on their own. "Grant's filing paperwork," she said, because if he'd overheard things on the 4th floor, he probably had a right to know where things stood. "Formally removing me from your case." "I know." His voice was flat. "He came up here an hour ago." She looked at him. "Grant came here. Said he wanted to inform me personally, as a courtesy." The word came out dry. "Told me the hospital took patient concerns very seriously and that I'd have an experienced nurse assigned in the morning." "What did you say?" "I told him his experienced nurse had better have battlefield triage experience and the ability to read a pressure trend, or I'd be making more noise than he wanted to deal with. That's not going to help." "I'm not trying to help, I'm trying to be accurate." He shifted in the bed, carefully, the way you moved when your body had stopped being entirely cooperative. "What are you going to do?" "About the reassignment?" "About all of it." She thought about how to answer that. The honest version was, she didn't know yet. She had a HR complaint forming against her, an administrator with institutional leverage and a donor relation motive, and a documentation trail that, if she were on the outside looking at it, might look like a nurse who'd been uncooperative with a difficult patient. The less honest version, the version she would have given anyone else, was that she'd address it through proper channels and trust the process. She didn't give him the less honest version. "I'm going to do my job," she said. "The rest is other people's decisions." He was quiet for a moment, then, "You've dealt with this before." "Dealt with what?" "Being dismissed by people who don't actually know what you are." She looked at him. The question had a weight to it that suggested it wasn't entirely about the hospital. "Get some sleep," she said. "The ICU team here is competent." "That's not an answer."
"No," she agreed and stood up. "It's not." She left the way she'd come in, through the double doors and out into the corridor that connected the ICU wing to the main building. She took the stairs down instead of the elevator because she needed the extra 30 seconds to think, and she thought about Raymond Holt's question not because it surprised her, but because it had been asked with the directness of someone who recognized something, and recognition, in her experience, was usually mutual.
She was in the parking garage when her phone rang. The number was unfamiliar, Colorado area code, but not one she knew. She answered out of the habit of answering. "Is this Nora Voss?" The voice on the other end was male, older, with the particular economy of speech that she associated with people who had spent years in environments where words were rationed. "Who's calling?" "My name is Dale Pruitt. I'm listed as Raymond Holt's emergency contact." She stopped walking. "Mr. Pruitt, your contact information is in the system. If you have questions about Colonel Holt's care, you should—" "I know what I should do." A pause that managed to be both brief and deliberate. "I'm calling you specifically, Ms. Voss, because Raymond called me this evening and told me what's been happening on the 4th floor. He also told me who you were and that the hospital is trying to pull you off his case. I can't discuss staffing decisions with—" "He told me your name. Said you were the only one on that floor who knew what you were doing." Another pause. "He also said you hadn't told him anything about yourself. So I did what you do when you're trying to figure someone out. I made some calls." She stood in the parking garage with the phone to her ear and said nothing. "You were with the 57th Medical Detachment," Pruitt said. 3 deployments. You cross-trained with 3 different line units, and you separated after a forward operating base in Kandahar province, where you were the primary medic for 14 hours after the doctor went down." The fluorescent light above her hummed. A car somewhere 2 levels up started its engine. "What do you want, Mr. Pruitt?" she said. "I want to know if you're going to fight this or let them move you off his case. That's not your decision or mine. Raymond's going to refuse the new nurse. That's his right as a patient. And it'll create enough disruption that they'll document it as a behavioral issue and use it against him." A beat. "And against you, probably, since you'll be the one who influenced him." She thought about that. It was accurate. It was exactly the shape of the thing Grant would construct if given the material. "I appreciate the call," she said. "I have to go." "Voss?" His voice hadn't changed in volume or tone, but something in the delivery sharpened. "He doesn't ask people for help, not ever. He called me tonight to tell me about you. That is not a thing he does." She sat with that for a moment. "Good night, Mr. Pruitt," she said, and hung up. She drove home, made herself eat something real, eggs because it was the fastest thing, and sat at the kitchen table without turning on the television because she didn't want background noise. She wanted to think. The HR complaint would be in the system by morning. Whatever she said or did from this point would be part of a documented record. That meant being precise. It meant not making the mistake of reacting instead of responding, which was something she'd learned the hard way in a context where the stakes for getting it wrong were considerably higher than a staffing dispute. She went to bed at 11 and lay there for 20 minutes before she accepted that sleep wasn't happening yet, and she got up and went to the small desk in the corner of her bedroom where she kept the things she didn't keep anywhere else. A locked box, an old notebook, 2 photographs in frames she'd stopped putting on the wall years ago because it got complicated when people asked about them. She didn't open the box. She just sat at the desk for a while with the lamp on, and in the morning she went back to Callaway Veterans Medical Center and did her job. The reassignment was official by 7 a.m. Deborah Falk delivered it in person, which Nora appreciated more than she would have said. The formal language was what it was: patient care continuity, staffing optimization, mutually agreed transition. And none of it was true. But it was in a document now. And documents had a way of becoming the only version of events that anyone could prove. "There'll be a meeting," Deborah said. "HR wants to do a review of the complaint documentation." "When?" "They said within 2 weeks." "That's within their standard timeline." Nora set the paper on the nurse's station counter. "Who's taking Holt's case?" "Brennan. He was Army, 2 years." "Did Grant choose him specifically because of the military background?" Deborah's expression confirmed what they both already knew. Yes. "Has Holt been told?" "He was informed this morning. Charge nurse in the ICU handled it." "How did he respond?" A pause. "He told the ICU charge nurse he wanted it noted in his record that he was refusing the transition." "They can't honor that. It's an administrative staffing decision." "I know. They documented the objection and moved on." Deborah looked at her with the kind of careful steadiness that came from genuinely not knowing what to say, but being unwilling to say nothing. "For what it's worth, and I know it's not worth much right now, this isn't right." "No," Nora said, "it's not." She went about her morning. The patients on her current assignment were straightforward: 2 post-surgical recoveries, a stable cardiac case being prepped for discharge, and an elderly woman admitted overnight for a urinary infection that had caught before it became something worse. Clean cases. Manageable. The kind of morning where a nurse could do the work without it costing anything extra. She hated it, not the patients. She never hated the patients. She hated the smallness of the morning, the way it had been arranged around her removal from something she'd already decided mattered. She hated that the most complicated case on the floor was 2 wings and a set of double doors away, and she was checking post-op vitals on a knee replacement that didn't need her specific attention. She did it anyway, because that was what you did. At 10:40, Brennan, the Army nurse who'd been given Holt's case, found her at the medication cart. He was younger than her by about 4 years, a compact man with the particular quality of someone who had learned to take up exactly the right amount of space and no more. They didn't know each other well. They'd worked a few shared shifts and had the kind of professional relationship that was cordial and hadn't needed to be anything else. "I need to talk to you about 412, he said, keeping his voice low. "He's in the ICU now." "I know, ICU Bay 6. He glanced over his shoulder, not paranoid, just checking the proximity of the nurse's station. "He won't let me do anything." She kept her face neutral. "Define won't let you." "I mean, he won't talk to me. He won't answer assessment questions, and when I went to update his intake form this morning, he told me to get out of his bay." A pause. "He said, and I'm quoting here, 'Go find Voss and tell her I'm not doing this.'" "That's a patient behavior issue for the ICU team." Nora. The use of her first name shifted something in the register of the conversation. "I'm not trying to step on whatever is happening here. I read the chart. I saw the pressure documentation and the cardiology notes. I know what happened yesterday." He paused. "He's not going to cooperate with me. And if he doesn't cooperate, his care suffers. That's not a staffing politics problem anymore. That's a clinical problem." She looked at him for a long moment. "Have you told Webb?" she asked. "Webb referred me to Grant because it's a staffing matter." "And Grant?" "Said to give it time, that patients adjust." She set down the medication she'd been pulling and turned toward him more directly. "What do you need from me?" "I don't know. I was hoping you'd have an idea. I'm not in a position to get involved in his care. I have documented reassignment and a pending HR review." "I know. If I go near that ICU bay, Grant has grounds to escalate." "I know that too." Brennan looked at her with the expression of someone who had presented a problem honestly and was waiting to see what happened. "I'm just telling you what's going on. What you do with it is your call." He walked away. She stood at the medication cart for a moment, hand flat on the cold metal surface. She thought about the Pruitt call the night before. She thought about Holt's face in the ICU bay, the particular way exhaustion and stubbornness had come together into something that looked almost like resolve. She thought about 14 hours in Kandahar province, which she hadn't thought about intentionally in a long time, And the way those hours had felt, not heroic, nothing like that, just one decision after another in the absence of any good options. She picked up her medication tray and kept moving. The escalation came at noon, and it came from a direction she hadn't entirely anticipated. She was at lunch, 30 minutes, cafeteria, coffee, and a sandwich she wasn't tasting, when the overhead page went out for a rapid response on the ICU. Not a code, not yet, but a rapid response meant something had changed fast enough that a nurse had made the call before it became a code. She was already standing when she heard Holt's bay number. She was through the cafeteria door before she'd made any decision she would have been able to explain. The ICU was controlled chaos by the time she pushed through the double doors. The kind of organized urgency that happened when experienced people responded to something they'd trained for but never wanted to see. She could see through the glass panel on Bay 6's door before she reached it. The team was there, Webb was there, the ICU attending was there, and the monitors were showing a rhythm she recognized. She stopped at the door. She was not supposed to be here. She was not on this case, not in this unit on any clinical basis, not supposed to be anywhere near Bay 6 of the ICU, and every institutional fact of her current situation said she should turn around and go back to her lunch. Raymond Holt's eyes found her through the glass. She went in. Nobody stopped her. She wasn't sure if that was because everyone was too focused on the patient to track who was in the room, or because no one wanted to be the person who created an additional scene in the middle of a rapid response, or because some part of the assembled team understood the way people who work in high-stakes environments eventually understand, that the metric that mattered right now was not who was assigned to whom on paper. She moved to the side of the bed where the line of sight was clear. The ICU attending, a lean woman named Dr. Farida Osei, was calling out orders, and the team was moving with the precision that the situation required. The rhythm on the monitor was still wrong, a flutter that suggested the cardiac inflammation had decided to make itself known more aggressively. Nora didn't speak. She didn't interject. She stood at the bedside and she watched, and when Holt's hand came up from the blanket in a weak, fumbling gesture toward her general direction, she reached over and put her hand on his forearm, not the IV arm, the other one, and held it there. "I'm here," she said quietly. "They know what they're doing." His hand stilled. Osei called out a medication dosage adjustment. One of the nurses confirmed. The rhythm on the monitor shifted. Not fixed, not yet, but responding. Someone recorded the time. The pace in the room dropped from urgent to focused, which was a good sign. After 3 minutes that felt considerably longer, Osei straightened up and turned, and her eyes went directly to Nora with the particular attention of someone processing an unexpected variable. "Nurse Voss," she said. "Dr. Osei." A pause that contained several things at once. Osei was looking at the way Nora's hand was on Holt's arm, looking at the monitor, looking at Holt, whose color was marginally better than it had been 30 seconds ago, and who was breathing with the careful, deliberate effort of someone who had decided to keep doing it. "He called for you," Osei said, "before the rapid response was called. He was agitated, he pulled the oxygen line, and his pressure spiked trying to get out of the bed." Another pause. The nurse on duty assessed it was stress-induced exacerbation. "That's a reasonable assessment," Nora said. "It is." Osei's expression was carefully neutral in the way that experienced attending physicians learned to be neutral when they were actually thinking several things at once. "You're not assigned to this patient." "No." "You're under an HR review." "Yes." Osei looked at her for a long moment. Then she looked at Holt, whose hand had relaxed under Nora's, and who had not, in the last 2 minutes, tried to get out of the bed or pull any lines or do any of the things that had apparently preceded the rapid response call. "I'll need to document your presence," Osei said. "I understand. And I'll need to notify administration." "Of course." A beat. Then something in Osei's face settled into a decision. "Stay until he's stable. I'll be back in 20 minutes. She walked out. The team thinned, leaving one ICU nurse running monitoring. Nora stayed where she was. Holt's eyes were open, still too bright with fever, but tracking. "You came," he said. "The rapid response went overhead. I was in the building." "You came," he said again, like the explanation didn't change the fact. She didn't argue with him. "You need to stop fighting the staff," she said quietly. "I understand why you're doing it. I'm telling you it's making things worse physically, not just administratively." They're using it against you. My situation is separate from your health. Your heart is having a worse time than it was yesterday. The inflammation is progressing, which means the antibiotics need time, which means you need to be calm enough for your body to actually use the medication. She kept her voice low and even. Not soothing. He didn't want that. Just level. Stressing your cardiac system right now is working against the treatment. His jaw was set. She could see the effort in it. The effort of a man whose default response to any threat, real or institutional, was to push back harder. "Holt," she said. He looked at her. "I need you to trust me that I can handle my own situation, and I need you to let the team here do their job." A pause. "Can you do that?" The silence that followed was the longest he'd given her since she'd met him. "I'll try," he said finally, which was not a promise, but was, from what she was beginning to understand about Raymond Holt, probably the most honest version of one he had. She stayed the 20 minutes. She stayed the 30 minutes. When Osei came back and the rhythm had stabilized, and Holt had allowed Brennan, who had quietly materialized in the bay doorway sometime in the last 10 minutes, and was standing there in the careful way of someone who had decided observation was more useful than assertion, to complete his assessment without obstruction, she finally stepped back. Osei walked her to the door. "He told me something," Osei said, low enough that it stayed between them, "while the team was working, before you came in. He was asking for you, and one of the nurses asked why you specifically, and he said—" She paused. "He said you'd carried soldiers home. That's what he said. I don't know what he meant." Nora looked through the glass at Holt, who had his eyes closed now, finally, the exhaustion taking over the stubbornness for at least a little while. "I'll leave the unit," she said. "Nora." Osei said her name with the particular weight of someone who was about to say something that existed in the space between professional and human. "Whatever Grant has put in that HR file, I'm going to add a note to today's rapid response documentation about patient stability correlation with provider presence." A pause. "It'll be clinical language, but it'll be accurate." Nora looked at her. "Thank you," she said. She walked out of the ICU and down the corridor and took the stairs again, the same ones she'd taken the night before, and this time she didn't stop to think. She went straight to her locker, pulled out her bag, and sat down on the bench alone in the empty changing room. She sat there for 4 minutes. Then she stood up, put the bag back in the locker, and went back upstairs. At 3 in the afternoon, Gerald Grant appeared on the 4th floor. She saw him coming from the nurse's station. Jacket, glasses on his face this time rather than pushed up, which meant he'd moved past the "I'm being serious" stage into the "I've already decided" stage. He had a printed document in his hand, and he walked with the particular purpose of someone who had made a decision and was arriving to communicate it. Deborah Falk was at the station. She looked at Nora once, quickly. Grant stopped in front of the station and didn't ask for a room. He was looking at Nora directly. "Ms. Voss," he said, "I've been notified of your presence in the ICU this afternoon. I responded to an overhead rapid response. You are not assigned to that unit. Any clinical staff can respond to a rapid response call. You were in Bay 6 specifically. Dr. Osei was aware and chose to utilize my presence for patient stability." She kept her voice exactly level. "It's documented in the rapid response notes." Grant's jaw moved in the way jaws moved when someone was recalibrating an approach. He set the printed document on the counter between them. "This is a formal notice of the HR review meeting, scheduled for next Thursday. During this period, you are expected to limit your interactions with patients not on your direct assignment." "Is that a policy document?" "It's a notice." "What policy does it reference?" A pause. "Patient care protocol?" "Can you give me the specific protocol number? I'd like to review it." The flush started at his collar. She'd seen it before, not on Grant specifically, but on the type. Men who were accustomed to delivering information downward, to people who would take it as delivered, and who encountered resistance not as a substantive challenge, but as a personal affront. "This is not a debate, Ms. Voss." "I'm not debating. I'm asking a question about the policy document." She looked at the notice on the counter without picking it up. "I'll be at the Thursday meeting. Is there anything else?" He picked the paper back up slowly and walked away. Deborah waited until he was out of sight. "That was either very smart or very inadvisable," she said. "I know the difference between a policy document and a management notice. He handed me a management notice and called it a policy." Nora went back to the chart she'd been updating. "There's a difference. He's going to come back harder." "Probably." She typed the last line of the note and saved it. "But he handed me something useful in front of a witness." Deborah was quiet for a moment, then carefully, "What are you going to do with it?" Nora looked up from the screen. "What I should have done the first morning," she said. She didn't say what that was, but the expression on her face was the same one she wore when she walked into a room where something had already gone wrong and she was deciding how to fix it. Not afraid, not angry, just present in the particular way of someone who had taken stock of the available resources and was beginning to work. 3 floors up, in ICU Bay 6, Raymond Holt's cultures had finally come back, and the results were not what anyone had expected. The attending physician read them twice. Then she reached for her phone and called Webb, and Webb called Shenkar. And within 20 minutes, there were 3 physicians standing around a printed lab report in the ICU conference room, speaking in the low, urgent tones of people who had just found something that changed the shape of a case they thought they understood. The infection in Raymond Holt's blood was not a standard septic organism. It was a rare treatment-resistant strain, the kind that didn't show up in community-acquired infections, the kind with a very specific transmission signature, the kind that raised questions about where it had come from and how long someone might have known. The lab report had a name at the bottom. The technician who'd run the culture, a woman named Solis who worked the early processing shift and who had flagged the result with a single handwritten asterisk before scanning it into the system. That asterisk was doing a lot of work. It meant she'd seen something unusual enough to mark it, without knowing yet what the marking would set in motion. Webb read the report a third time, which Shenkar noticed. "You're reading it like it's going to change," she said. "I'm reading it like I want to make sure I understand it before I say it out loud." He set the paper flat on the conference table. "Burkholderia pseudomalae." Shenkar crossed her arms. "Melioidosis. In Colorado, in a 71-year-old retired colonel with no recent travel history." She said it the way physicians said things they already knew were true but needed to hear in sequence. "Who has been home for the last 4 months. His intake form was specific. No international travel in over 2 years, no known exposure contacts." Which means either the intake form is wrong or the exposure wasn't recent. The ICU attending Ose had been standing at the window with her back to them. Now she turned around. "Melioidosis has a documented latency period, months, sometimes longer. If he was exposed during his service, that was decades ago," Webb said. "Latent Burkholderia reactivation has been documented in veterans. It's rare, but it's not unheard of." Ose moved to the table. "There are cases from Vietnam-era veterans presenting 30, 40 years post-exposure, usually triggered by immunosuppression or significant physiological stress. His immune profile on admission wasn't flagged. He's 71. He lives alone. He waited 2 days with a fever before anyone found him." She looked at Webb directly. "That's physiological stress." The room went quiet in the particular way rooms went quiet when people were doing the math on something uncomfortable. "He needs to be on the melioidosis protocol," Shenkar said finally. "Ceftazidime IV, intensive phase, minimum 10 days before we even talk about eradication therapy. He's already on cefepime, which is doing nothing for Burkholderia. We need to transition the antibiotic regimen today." She was already pulling up the prescribing protocol on the wall screen. "And we need to notify the county health department. This is a reportable organism." That's going to generate attention. It's going to generate the appropriate attention. Shenkar's voice had the clean, unambiguous quality of a physician who had stopped finding the administrative dimensions of medicine interesting. "What else do we tell them?" Webb looked at the lab report again. "We tell them we have a veteran with a rare tropical pathogen presenting in a non-endemic region with no obvious exposure route." He paused. "And we document everything from this point forward very carefully." Nobody said what the third thing was, the thing that sat underneath the clinical facts like a foundation nobody wanted to look at yet. Burkholderia pseudomalae didn't spontaneously materialize in Colorado. It came from somewhere. And if the exposure hadn't been recent and hadn't been documented, and the patient himself didn't know when or how it had happened, then the question of where it came from was not going to stay a clinical question for very long. Nora found out the way she found out most things that she wasn't supposed to know, from the pharmacy. The antibiotic transition order came through the medication system at 4:20, and the pharmacist, a careful, overworked man named Ruiz, who had a habit of flagging unusual orders with a quick message to the nursing staff because he'd caught 2 serious interaction errors that way in the last year, sent her a brief internal note out of habit before he caught himself. Ceftazidime IV for Holt, 412/ICU-6. Unusual choice for the presentation. Culture result must have been interesting. She read it at the nurse's station, read it again. Then she looked up Burkholderia pseudomalae on the clinical database, not because she didn't know what it was, but because she needed to see the words on a screen in front of her before she let herself react to them. She'd seen melioidosis once, not in a hospital, in a field environment, in a country where the soil itself carried the organism, where a man from her unit had developed a fever that everyone initially attributed to the heat and the water and the 100 other things that made soldiers sick in that part of the world. She'd been the one who'd pushed for the culture, back when pushing for things like that was considerably harder than it sounded. She'd been the one sitting with him while they waited for the result. He'd survived. She closed the database window and sat for a moment. Then she went to find Webb. He was in the physician workroom, typing notes, and he looked up when she knocked on the open door with the expression of a man who had been expecting this conversation without knowing exactly when it would arrive. "Voss? The culture came back," she said. "How did you—" He stopped, recalibrated. "It doesn't matter. Come in." She closed the door behind her. "Burkholderia," she said. "Yes. He needs to be told. The attending will tell him." "When?" "This evening. They're preparing the conversation." Webb looked at her with the careful attention of someone managing multiple concerns simultaneously. "Nora, you know you're not in a position to be in that room." "I know." "Grant has already sent a second notice about the ICU visit. I'm not going to the ICU." She sat down without being invited, which wasn't something she usually did. "I need to tell you something about Colonel Holt that isn't in his chart." Webb waited. She thought about how to say it. She'd carried this for a long time. Not as a secret exactly, more as something that had never needed to be said in a medical context because the context had never required it. You didn't walk into a hospital and announce your service record. You did your job. The job was the job, regardless of what had come before it. But the job had changed. "I was attached to the 57th Medical Detachment," she said. 3 rotations, 2 theaters. On my last deployment, Kandahar, 2009, my unit was embedded with a larger task force for a joint operation. I didn't know the task force designation at the time. I was a staff sergeant. I knew my lane. I knew the FOB I was working out of. I knew the forward element I was running medical support for. She paused. I found out later, after I was back stateside, that the task force I'd been co-located with for 3 months was commanded by a colonel named Raymond Holt. Webb did not move. "I didn't know that when he was admitted," she said. "I recognized the name when I read his chart, but I wasn't certain. It's a common enough name. I didn't know for sure until he described, in the ICU, the second day, a series of engagements from that period, details that placed him specifically." She looked at Webb directly. "I should have disclosed the potential connection earlier. I didn't, partly because I wasn't sure, and partly because I didn't think it was clinically relevant." "Is it clinically relevant now?" "Yes." She folded her hands in her lap. "Because if Colonel Holt was operating in Kandahar province in 2009, he was operating in a region where Burkholderia pseudomalae is endemic in the soil. And because the operation his task force was running, I don't know the full scope of it, I was medical support, not intelligence, involved a forward element that worked in terrain conditions that would represent significant exposure risk." A pause. "He may not know when he was exposed. He may not have been sick. Latent carriers don't always develop symptoms until decades later." Webb was quiet for a long moment. "Does he know you were there?" he said. "At the FOB during that deployment?" "No." "I don't think so. He wouldn't have had reason to know who the attached medical staff from the co-located detachment were. I was a staff sergeant. He was running a task force. But you knew his soldiers. She thought about that. About the specific people. About a 23-year-old corporal named Walsh who had died in the medical bay of a faux bee in Kandahar province on a Tuesday morning in March 2009. And about a 26-year-old sergeant named Breckenridge who had lasted 2 more days. She thought about their names the way she thought about all the names she carried. Not constantly, not every day, but in the particular way that certain things get incorporated into the structure of who you are without your permission. I knew some of his soldiers, she said. Webb looked at her for a long time. This changes the clinical picture significantly. If we can establish an approximate exposure window, the treatment trajectory, yes. And it changes the HR situation. I know. Grant's complaint is based on the premise that you had no applicable military experience. If your service record is relevant to the patient's case, that's not why I'm telling you. She looked at him steadily. I'm telling you because it's medically relevant and because the patient has a right to know that his physician has access to information that might help them understand his exposure history. She paused. What you do with the rest of it is your decision. Webb sat back in his chair. I need to make some calls, he said. I know. This is going to be a longer conversation than either of us planned for this afternoon. I know that too. She stood. Tell Dr. Osei about the Kandahar connection before she speaks to him tonight. It'll affect how she approaches the exposure timeline discussion. She moved toward the door. And Webb, he's going to have questions she won't be able to answer. Clinical ones, yes, but also other ones. About the soldiers, about what he might have missed. She put her hand on the doorframe. He's been carrying something for a long time. The diagnosis is going to shake it loose. Webb said nothing. She went back to her patients. She was 2 hours into the close of her shift when the ICU called the 4th floor looking for her. Not Webb, not Osei. The call came from the unit clerk, and the message was simple. Colonel Holt is asking to see you. Dr. Osei has been informed. She says it's your call. She told the clerk she'd be up in 15 minutes. Deborah caught her at the elevator. Grant's going to find out you went up there. Yes. Nora. Deborah. She said it gently, which was the version that meant I've already thought through this and I'm going anyway. He just found out he's carrying a pathogen that's been living in his body since Kandahar. He doesn't have family. He has a friend in another state who he called once. She looked at the elevator doors. Someone should be there. Deborah stepped back, said nothing, which was her version of go. The ICU was quieter at 6 in the evening than it had been at noon. The rapid response energy was long gone, replaced by the steady, measured atmosphere of close monitoring. The beeps at regular intervals, the soft movement of staff between bays, the quality of attention that the unit ran on in its normal state. Osei met her outside Bay 6. He knows, she said. I told him an hour ago, walked him through the organism, the latency, the treatment plan. How did he take it? He asked 3 clinical questions. Specific, accurate questions. He'd clearly had medical briefings before. He knew how to absorb information under pressure. Then he went quiet. She paused. He's been quiet since. Has he talked to anyone? He asked for you. Nora nodded and pushed through the curtain. Holt was sitting up in the bed at the same angle as before, but something in the posture had changed. Not collapsed. He wasn't a man who collapsed. But the particular rigidity he'd been holding since admission was different now. Like a load-bearing structure that had had something removed from it. He looked at her when she came in. She pulled the chair close and sat down without saying anything, because sometimes the most useful thing you could do was be present without filling the space. He looked at the monitors for a while. Kandahar, he said. Yes. You knew. I suspected, based on the culture result and the regional history. I told Webb this afternoon. He told me. A pause. He also told me you disclosed your own connection to the area, to my unit. She didn't respond. You were at Firebase Kestrel, he said. It wasn't a question. I was attached to medical support at a co-located FOB.
I didn't know the designation of your task force while I was there. But you knew the men. He turned his head and looked at her directly. Walsh and Breckenridge. The names in his mouth hit differently than they did in her own memory, which surprised her. She'd said their names in her own head for 15 years without it feeling like this. Yes, she said. Something moved across his face. Not grief exactly, or not only grief. Something older and more complex, the kind of thing that had been lived with for so long it had changed shape. I've been over that week 10,000 times, he said. The order I gave, whether I should have held the element back, whether the routing was right. His voice was even, the way voices got even when the thing being described was too big for expression. Walsh was 23. Breckenridge was 26. I put them in that position. You gave a tactical order based on the intelligence you had, she said, and they died. They did. She didn't soften it. He wasn't asking for softening. They also achieved the objective. The position they took out. She stopped, thought about how to say what she knew. I found out afterward. Not immediately. I was stateside by then, but eventually. The intel that came out of that operation, the route interdiction your element executed, it stopped a truck bomb that was staged for the main convoy. Command estimated 200 personnel. He looked at her. Walsh and Breckenridge knew what they were doing, she said. They weren't lost because of a failed order. They were lost because of a war and because they were good at what they did. The silence was different this time. Not resistant. Something had gone out of it. You held Breckenridge, he said quietly, at the end. It was not a question. Yes, she said. His jaw moved, stopped. He put his fist against his mouth for a moment, a brief, controlled gesture, the kind that came from decades of not doing this in front of anyone. He wasn't alone, she said. I need you to know that. He nodded once, jaw still working. She let it go. Let the silence have its time. After a while, he said, Why didn't you tell me who you were? When I was being... He stopped. Didn't finish the insult's description of himself. Because it wasn't relevant to your care, she said. And because people don't owe anyone their service history as a credential. A pause. You were sick, and you were frightened, and you were covering it with anger. I've worked with that before. I didn't need your respect to do my job. He looked at her for a long time. You should have it anyway, he said. She didn't say anything. I want to speak to Webb, he said, and whoever is running this review that Grant is filing against you. I want to make a formal statement. That's your right, but it's not why I told Webb about the deployment connection. I know why you told him. His voice had shifted again. Steadier now, the way voices got steady after something had been released. But I'm going to make the statement regardless. She started to respond and stopped, because the monitor above his head had emitted a sound that was different from the regular pattern. Not alarming, not yet, but a variance that she caught in the same automatic way she caught all clinical changes, the part of her brain that had been trained to filter for exactly that frequency. She stood up and looked at the screen. The rhythm was there. The pressure reading was wrong. Not critically. Not what it had been at noon, but the downward tick was back, and it had moved in the last 30 seconds. Holt, she said. He looked at her face and seemed to understand something from what he saw there. What is it? She was already at the door. I need to get your nurse. She flagged Brennan from across the unit floor. He was at the station. He saw her face. He was moving before she said a word. She gave him the readout in shorthand on the way back to the bay. Pressure drop, timing, the context of the day. The antibiotic transition that had started 4 hours ago and hadn't had time to build therapeutic levels. Brennan assessed, called Osei, and within 6 minutes the bay was occupied again. Not with the urgency of the noon rapid response, but with the focused, systematic attention of a team managing a patient who was fighting an infection that had had 15 years of practice staying alive in a human body. Nora stood outside the bay. She had done what she could do. The team had it. She was not assigned here, not officially, not on paper, and the next correct move was to step back and let the people with the assigned roles do their work. She stepped back, watched through the glass. Brennan was competent. She could see it in the way he moved, the economy of it, nothing wasted. Osei was steady. The medication adjustment went in smoothly and the monitoring continued, and Holt,
who was still awake, still watching, had his eyes on the glass panel in the bay door in a way that she chose not to interpret too specifically. She turned to leave. Voss? Osei behind her. She stopped. Osei was holding a tablet. She extended it so Nora could see the screen. This just came through from the county health department. They responded faster than I expected. They treat Burkholderia notifications as priority. She paused. They're sending an epidemiologist tomorrow morning. Standard protocol for a rare organism in a non-endemic region. That's appropriate. Yes. Osei looked at her with the expression that had become familiar over the last 2 days. The one that said, I am navigating several things at once, and I want you to understand the shape of them. They asked if the patient has any contacts who may have shared the exposure, anyone from his unit who might be asymptomatic carriers. Nora was quiet for a moment. That's going to be a significant list, she said. I know. They'll need medical records from his unit's deployment, which means, depending on how classified that material is, it may involve Veterans Affairs, possibly DOD. Yes. And it means whatever happened in Kandahar in 2009 is going to get looked at by people with resources and authority considerably beyond a county health department. Nora said nothing. I thought you should know the shape of what's coming, Osei said. I appreciate that. She walked toward the double doors, pushed them open, moved into the corridor. Behind her, in Bay 6, the monitors continued their rhythmic accounting of a man who had come into this hospital carrying more than anyone had known, a rare organism in his blood, a 15-year wait in his chest, and a story that was now in the hands of more people than either of them had planned for. She was halfway down the corridor when her phone buzzed, a message from a number she didn't recognize. No name. Colorado area code, but different from the one Pruitt had called from. You don't know me. My name is Whitfield. I was Intel S2, Task Force Iron Wolf, Kandahar, 2009. I heard what's happening with Colonel Holt. I need to talk to you before the epidemiologist arrives. There are things about that week that the medical records won't show, things that matter to what happened to those men. Call me. She read it twice. Standing in the corridor outside the ICU, in the hospital where she had been formally removed from a case, where her HR file was accumulating documentation, where a county health investigation was arriving in the morning, she read it a third time. Then she put the phone in her pocket and stood very still. There were things about that week that the medical records won't show. She'd been in enough operations to know what that sentence meant. She'd heard it before, in different forms, in different places. It meant that somewhere between what was officially documented and what had actually happened was a gap, and in that gap was the thing that explained everything that came after. Walsh, Breckenridge, the truck bomb, the routing, the order Holt had been carrying guilt about for 15 years. She pulled her phone back out and looked at the message again. If Whitfield was who he said he was, S2 Intel, task force level, he would have known things that a staff sergeant running forward medical support would never have been read into. Things about the intelligence picture that week, about what command had actually known and what they'd chosen to act on and what they'd chosen not to say. She scrolled to the number. Her thumb was over the call button when the door at the end of the corridor banged open. She looked up. Gerald Grant was walking toward her with a printed document in his hand and an expression that had moved past administrative disapproval into something considerably more deliberate. And behind him, walking 2 steps back, was a man she didn't recognize. 50s, civilian clothes, the particular upright quality of someone who was carrying authority from somewhere else, who was looking at her with the steady, evaluating attention of someone who had been briefed on who she was before he walked through that door. Grant stopped in front of her. Miss Voss, he said, this is Mr. Denton from Hospital Legal. We need you to come with us. She put the phone in her pocket slowly. Right now? She said. Right now, Grant said. We have some questions about what you shared with Dr. Webb this afternoon, specifically about your military service record and why that information was withheld from hospital administration during your employment. She looked at Denton, who had said nothing and was still watching her with that evaluating stillness. Am I being terminated? She said. Grant's jaw tightened. We're asking questions. That's not an answer to what I asked. Denton spoke for the first time. His voice was measured and uninflected. The voice of someone who chose words with the care of someone who was already thinking about how they'd read in a document. Ms. Voss, he said, we've also received a contact from the Department of Defense, Joint Health Affairs Division. He paused, just briefly. They're asking questions too, about your deployment history, and about what you may have shared with the patient in Bay 6. The corridor was very quiet. She held Denton's gaze. Then we should probably all sit down, she said. The conference room on the second floor had been designed for the kind of conversations that administrators preferred to have away from patient care areas. Beige walls, a long table that could fit 12 but currently held 3, a whiteboard with someone's scheduling note still on it from 2 days ago that no one had bothered to erase. Nora sat on one side. Grant and Denton sat on the other. A hospital legal assistant Nora had never seen before was in the corner with a laptop, typing. Nobody offered her water. She noticed that. Denton led, which told her this had moved past Grant's operational authority into something that required a different kind of management. He had a folder, actual paper, which said either that he'd printed it recently or that he came from a generation that still trusted physical documents over screens. Ms. Voss, he said, I want to be clear about the nature of this conversation. You are not being terminated at this time. This is an informational review, and you are welcome to have a union representative present if— I don't need a representative, she said. Ask your questions. Denton looked at her for a moment. Grant shifted in his chair. During your employment intake, Sinad, Denton said, you listed your prior work history as civilian trauma nursing, travel nursing contracts, and a 2-year gap described as personal leave. You did not list military service. The intake form asked for employment history. Military service is not categorized as employment on that form. It has a separate disclosure field, which you left blank, which asks if you have current military affiliation or active reserve status. I have neither. A pause. Grant opened his mouth, and Denton put a hand up, barely. Just a slight movement of 2 fingers that nonetheless stopped Grant completely, which told Nora something about the internal hierarchy of the room. Were you aware, Denton said, the Callaway Veterans Medical Center has a Veterans in Healthcare initiative that provides staffing preference to qualified applicants with military medical experience? I was aware. And you chose not to disclose. She looked at him evenly. I chose not to use a preference program that I didn't feel I needed in order to get the job I was qualified for. Some would say that's withholding material information. Some would say that's privacy. She kept her voice unhurried. My DD-214 is a personal document. I'm not legally required to disclose my service record to a civilian employer. The intake form didn't require it. I didn't offer it. A pause. If the hospital's position is that nurses with military backgrounds are required to disclose that history as a condition of employment, that policy doesn't exist in any document I've signed. I'd like to see the policy cited if you're going to use it as grounds for disciplinary action. The typing in the corner paused. Denton looked at her, then at the folder. Grant's face was doing the thing it did when a conversation had moved away from him, the controlled frustration of someone watching their framework become unreliable. The DOD contact, Nora said. You mentioned Joint Health Affairs. What specifically did they ask? They asked whether you had disclosed classified operational information to the patient in Bay 6, Denton said. No. You're certain? I told Colonel Holt that the soldiers who died in his operation did not die because of his command decision. That's not classified. That's a statement about the nature of the engagement that came from after-action reports that were summarized in declassified debriefs available through the National Archives. She watched his face. I can give you the document number if you need it. The typing started again. Grant leaned forward. He'd been quiet for too long, which was never a state he maintained comfortably. None of this addresses the central issue, which is that you were formally removed from Colonel Holt's case and you continued to involve yourself. I responded to an overhead rapid response. Any clinical staff member can and should respond to an overhead rapid response. Dr. Osei documented my presence and chose to utilize it for patient stability. She turned toward him with the steady attention she normally reserved for vital sign trends that needed watching. The formal removal you're referencing is a management notice, not a policy document. I asked you for the policy citation yesterday. You didn't provide one. She looked at Denton.
I'd like it on record that the notice Mr. Grant provided yesterday did not reference a specific hospital policy by number or title. The legal assistant can note that. The typing paused, then resumed. Grant's color was bad in the particular way that happened when someone had walked into a room expecting to hold ground and found the ground had already moved. Denton closed the folder. "We'll need to continue this tomorrow," he said. "The DOD inquiry is ongoing and I'd prefer to have their initial report before we finalize anything on our end." "I'll be here," she said. She stood up, took her badge from the table where she'd set it when she sat down. She didn't know exactly why she'd done that. It had been instinct, some habit from a context where you accounted for your equipment before a conversation began, and clipped it back to her scrub pocket. "Ms. Voss," Denton said as she reached the door. She turned. He was looking at her with an expression she hadn't seen from him yet. Not the evaluating stillness, something more candid and less curated. "The DOD contact didn't only ask about you," he said. He seemed to be making a decision as he said it, choosing the words with the care of someone who understood they were crossing a line but had decided it was the right line to cross. "They asked about the patient's records, about the exposure documentation, about whether anyone at this hospital has discussed the operational context of his deployment with him in the last 48 hours. He paused. "That's an unusual set of questions for a health inquiry." She looked at him. "Yes," she said. "It is." She left. She called Whitfield from the parking garage. It rang twice before he picked up. His voice on the call was the same as the text. Controlled, economical, with the underlying quality of someone who had spent years being careful about what they said and to whom. "Voss? You said there are things about that week that the medical records won't show," she said. "Tell me what you mean." A pause, not hesitation. Deliberation. There was a difference. "Not on the phone," he said. "I don't have time for—" "This is not a conversation for a phone." His voice had shifted slightly, the way voices shifted when someone needed you to understand something without being able to say it directly. "Where are you?" "Callaway, parking garage, level 2. "I'm 40 minutes out. There's a diner called Rayford's on Clement Street, 3 blocks from the hospital. I'll meet you there in an hour." He hung up before she could respond. She sat in her car for a moment, hands on the wheel, not starting the engine. The DOD contact. Joint Health Affairs asking about operational context. An S2 intel officer from Task Force Iron Wolf who'd tracked down her number from God knows where, reaching out the same day the culture result landed. None of those things were coincidental, and she'd been in enough situations to know that when multiple pressure points activated simultaneously, it was rarely spontaneous. She started the car. Rayford's was the kind of place that had been there long enough to stop caring whether it looked inviting. Vinyl booths, fluorescent lighting, a menu laminated over so many times the prices from 3 versions ago were still visible underneath the current ones. She got there first and took a booth near the back, facing the door. Whitfield walked in at 7:43. He was 56, she estimated, or thereabouts. The kind of age that sat differently on people who'd been in hard places. Medium height, civilian clothes that looked mildly uncomfortable on him, the way civilian clothes sometimes looked on people who'd worn a uniform for decades. He spotted her immediately, which meant he'd known what she looked like before he walked in, which was worth noting. He slid into the booth across from her without greeting. "You made contact with the county health department this morning," he said. "The hospital made contact. I had nothing to do with the reportable disease notification. But you're the one who connected the culture result to Kandahar. Webb made the clinical assessment. I provided contextual information." He looked at her with the flat, appraising look of someone who was deciding how much directness to use. He apparently decided on a lot. "In 2009, he said, Task Force Iron Wolf was running a joint operation with a partner intelligence unit. The operation involved a series of interdiction actions in Kandahar province, targeting a specific logistics network." He paused. "The intelligence picture that week included information about a potential biological exposure risk in the operating area, a soil contamination profile that had been flagged by a USAMRIID assessment 6 months earlier." She kept her face still.
That assessment indicated elevated Burkholderia pseudo-Mali concentrations in the soil in two specific grid sectors, he said. Sectors that the forward element, Walsh and Breckenridge's position, was ordered to operate in for approximately 72 hours. The diner noise continued around them. Someone's coffee cup hit the counter. A family in the front booth was arguing cheerfully about something on a menu. That assessment was classified, she said slowly, and it wasn't shared with the forward element. He didn't answer. He didn't need to. Command knew there was a biological exposure risk in those grid sectors, she said, and they sent men in anyway, without telling them. The operation was time-sensitive. The assessment was considered, and I'm using the language from the after-action documentation here, low probability for acute exposure given operational tempo. Low probability. She sat with that. Walsh developed a fever within 6 months of redeployment. Breckenridge was dead within a year. Both attributed to other causes at the time. Because no one was looking for Burkholderia. She looked at him. Because if anyone had looked for it, they'd have found the USAMRIID assessment and the deployment records, and they'd have had to explain why men were sent into a known exposure zone without being informed. Whitfield was quiet. How many others, she said. From the forward element specifically. Walsh and Breckenridge are documented. There are 3 other veterans from that operation with unresolved chronic infections on record. One died in 2017, cause of death listed as sepsis, underlying cause unclear. He put his hands flat on the table. And Raymond Holt, who was at that FOB for the duration of the operation and whose exposure would have been consistent with the same environmental profile. She processed that in the deliberate way she'd learned to process information that required action. "Why are you telling me this?" she said. "Because the DOD contact to your hospital wasn't from Joint Health Affairs." He said it simply, without drama, which somehow made it worse. Joint Health Affairs was notified because the culture result triggered a standard reportable disease flag. But the contact to your hospital's legal department, the one asking about operational context and what you'd told Holt, that came from a different office. General Counsel, Defense Health Agency. They're not trying to investigate, they're trying to assess exposure. They want to know what Holt knows, and what you know, before the epidemiologist gets there tomorrow morning and starts pulling on threads that lead back to a classified assessment that was supposed to stay buried. She looked at him directly. "Why does this matter to you?" A pause. He looked at the table, then back at her. "Walsh was 23, he said. "I briefed his element the morning before they went into that sector. I knew about the USAMRIID assessment. I didn't have authority to share it. It came from above my lane. But I knew." He stopped. "I've known for 15 years. The diner moved around them. She didn't say anything immediately. "What do you need from me?" she said. "I need you to understand what's coming. The epidemiologist tomorrow is from the county, not DOD. That's good. But DOD's general counsel is going to try to get ahead of this. There will be a call to the hospital board, probably tonight or first thing tomorrow. They're going to reframe the exposure as a novel clinical finding unrelated to the operational record. They're going to try to disconnect Holt's case from the 2009 assessment. And if Holt doesn't know about the assessment, he can't contradict the reframing." Whitfield looked at her steadily. "But if someone tells him tonight, I've been formally removed from his case and my employment is under review." She kept her voice even. "If I walk into that ICU again, I know." He reached into his jacket and put a USB drive on the table. She looked at it. The USAMRIID assessment. The deployment grid coordinates, the after-action summary from that week that references the biological exposure risk categorization. A pause. Declassified last year as part of a broad review. Technically accessible, but not something anyone from that chain of command has been eager to put in front of a physician. She looked at the drive. "That goes to the county epidemiologist," she said. "Not through me. If I hand that to anyone right now, DOD General Counsel will use it to reframe me as the problem." "I know. I'm not asking you to hand it to anyone." "Then what are you asking?" "I'm asking you to know it exists." He left the drive on the table. "The rest is your judgment." She picked it up, turned it over once in her fingers, put it in her pocket. "I need to make a call," she said. "I'll wait."
She stepped outside into the cooling evening air and called Dale Pruitt. He answered on the second ring. "Boss, Colonel Holt needs to know something before tomorrow morning," she said. "I can't be the one to tell him, but you're listed as his emergency contact, which means you have full visitation rights regardless of the hour, and you have the right to share information with him about his own medical history." A pause. "Tell me." She told him. All of it. The USA MRIID assessment, the grid sectors, the deliberate omission, the DOD General Counsel contact. She kept it factual and sequenced, the way she gave clinical briefings, because this was a clinical situation even when it was also everything else. Pruitt listened without interrupting. When she finished, the silence on the line had the particular quality of a man absorbing information he'd been suspecting for 15 years without ever having the pieces to prove it. "He needs to hear it before they get to his physicians," she said. "If he knows, he can speak for himself. If he doesn't, he'll be maneuvered around," Pruitt said. "I understand." A breath. "I'll drive tonight. It's 3 hours. I've driven farther for less." He paused. "Boss, this is going to get loud." "I know." "Are you ready for loud?" She thought about that. About the conference room, and Denton's evaluating eyes, and Grant's folder, and the legal assistant typing in the corner. About the USB drive in her pocket, and the message from Whitfield and the county epidemiologist arriving in the morning. About Raymond Holt in Base 6, who had been carrying guilt for 15 years about an order that hadn't killed his men, exposure that someone above the task force level had known about and chosen not to share had done that. And about Walsh and Breckenridge, whose names she'd carried quietly for long enough. "Yes," she said. She went back inside. Whitfield was still in the booth, coffee in front of him now, waiting. "There's one more thing," he said when she sat down. She looked at him. "The DOD General Counsel contact to your hospital, the one asking about what you'd shared with Holt." He wrapped both hands around his coffee cup. "They used your name specifically, not the treating nurse. Your name." She processed that. "Which means they knew I was involved before they called," she said. "Before the reportable disease notification. Before the culture result was in the system long enough to generate the standard flag." He paused. "Someone notified them about your connection to the deployment before the clinical picture became clear." She sat with that. "Who knew I'd been at that FOB?" she said. "Outside of what I told Webb this afternoon." "That's a short list," Whitfield said. "I knew. Webb knew as of this afternoon. Holt knew as of this evening." A pause. "And anyone who had access to the deployment records and the staffing manifests from the co-located medical detachment." "That's a classified record." "Yes." "Which means whoever pulled it had the access and the reason to look." "Yes." She thought about the shape of it. Someone with DOD access had pulled deployment records specifically looking for her name, had found the connection to Firebase Kestrel and Task Force Iron Wolf, and the 2009 operation before the hospital had even processed the culture result, had notified General Counsel's office in time for them to make a call to Callaway's legal department on the same day the result came back. That wasn't reactive. That was prepared. "They've been watching Holt," she said. Whitfield said nothing, which was the same as saying yes. "For how long?" "That's the question I don't have a clean answer to." He looked at his coffee. "But the General Counsel's office doesn't mobilize that fast on a routine reportable disease notification. The system flag goes to the county first. DOD Health typically responds in 72 hours minimum." He looked up. "They called your hospital within 4 hours of the culture result being entered." 4 hours. She did the math automatically, the way she always did. Timestamps were clinical. Timestamps were everything when you were trying to establish a sequence. "Someone in this hospital notified them before the official flag went out," she said. The diner was suddenly very loud. Not louder than before, exactly the same volume as before. But she heard it differently now. She looked at the table, at her coffee cup, which she hadn't touched. "Who would have had access to the culture result in the first hour?" she said, already knowing the answer, already arranging the facts into the shape they made. "Whoever was watching the lab system," Whitfield said. She thought about the timeline. The result had come in at 4:20. Ruiz, the pharmacist, had messaged her within minutes out of habit. The antibiotic transition order had gone through the system by 4:40.
The DOD General Counsel contact to the hospital's legal department, Denton had alluded to it, hadn't given her a time. "When did Denton receive the DOD call?" she said. "I don't know exactly. I need to know if it was before or after 5 p.m. "Why?" "Because at 5 p.m., the lab system administrator's monitoring dashboard resets for the end of business access log. Any query run on a patient record before 5 doesn't roll over to the next day's report." She looked at him. If someone pulled Holt's record and cross-referenced the culture result before 5, it would be in today's access log, which hasn't been reviewed yet. Whitfield looked at her with the expression of someone recalibrating. "You'd need the hospital's IT system access logs," he said. "I'd need someone with the authority to request them." She thought. The county epidemiologist has broad investigative authority on a reportable disease case. She could request the access logs as part of establishing the notification chain. That's a stretch. It's defensible. She looked at him directly. If someone in this hospital was monitoring Holt's records and notifying DOD before the official channel processed the result, that's not just a legal problem for the hospital. That's obstruction of a public health investigation. Whitfield sat back. He was quiet for a long moment, doing the kind of thinking that happened in long silences. "You've done this before," he said. "Not medicine. This." She didn't answer that. "Who's the epidemiologist?" she said. "Dr. Annette Forsyth, County Communicable Disease Division. I know her reputation. She's rigorous and she doesn't back down from institutional pressure." "Good." Nora stood, left money on the table for the coffee she hadn't drunk. "I need to be at the hospital when she arrives tomorrow morning." "You're under an employment review." "I'm still employed. The review hasn't concluded." She picked up her bag. "And Dr. Forsyth is going to need someone who understands the clinical picture of Holt's case from admission. Someone who documented the pressure trend, the antibiotic history, and the timeline of the exposure conversation." She met Whitfield's eyes. "That's me." She walked to the door and pushed out into the evening. She didn't sleep much, not because she was anxious exactly. It was a different state than anxiety, the one she remembered from certain nights before certain operations where you knew the shape of the next day well enough to know sleep was an inefficiency you'd chosen not to afford. She spent 2 hours organizing everything she knew into a sequence that held, checking the logic of it, the way you checked equipment, looking for the thing that would fail under pressure. There was one gap. She knew who had contacted DOD General Counsel. She was nearly certain. The timeline, the access, the motive all converged on the same place. But nearly certain was not the same as documented, and without documentation, the gap was exploitable. Someone could step into it and reframe everything she'd built into something that pointed back at her. She needed the access log. At 6 a.m., she sent a message to Webb, clinical, specific, stripped of everything that wasn't factual. The DOD General Counsel contact occurred within 4 hours of the culture result entering the system. This is faster than the standard reportable disease notification chain. I believe the patient's EMR was accessed by someone who then notified DOD independently. The county epidemiologist should request today's system access log before it rolls over in the next business cycle. This is relevant to the integrity of the public health investigation. She sent it and set her phone down and made coffee. Webb replied in 11 minutes. No preamble. "I forwarded this to Dr. Forsyth. She's arriving at 8. She arrived at the hospital at 7:45. So, Forsyth was not what Nora had built in her head from Whitfield's description. She was 50, small, with reading glasses perpetually either on her face or pushed up into her hair, and the particular energy of someone who ran on information the way other people ran on sleep. She had 2 people with her, one from the county, one Nora didn't recognize, who had the quiet peripheral attention of someone from a federal agency, though no identification was offered. They met in the hospital's administrative conference suite, which was different from the beige second-floor room, larger, with the kind of table that had been bought to impress rather than function. Forsyth did not appear impressed. She had a laptop and a thick folder, and she'd clearly read everything Webb had sent her because she came in without the usual orienting questions. "You're Voss," she said when Nora entered. "Yes." "You were the admitting nurse, the 4th-floor nurse on his first day. I've been formally reassigned since, but I've been involved in the case." Forsyth looked at her over her glasses with the efficient attention of someone who categorized people quickly and filed them accurately. I read the rapid response documentation, and OC's note about provider presence correlation. Dr. Ose's assessment. Your presence? Her assessment. Forsyth set her glasses on her face properly. I'm going to need your clinical timeline, full documentation, start to finish. A pause. And I'm going to need you to tell me why you sent Webb a message about system access logs at 6 in the morning. Nora told her. She laid it out the same way she'd organized it overnight, sequenced, documented where documented, clearly labeled as inference where it was inference. Forsyth listened without interrupting and with the particular quality of attention that meant she was building a parallel structure in her own head as Nora spoke, checking the logic, finding the same gaps, running the same tests. When Nora finished, Forsyth said, You're suggesting someone in this hospital contacted DOD General Counsel before the official notification channel processed. I'm suggesting the timeline is inconsistent with standard notification procedures. The access log would confirm or disprove it. Forsyth looked at the person from the unidentified federal agency, who gave a small nod. I'm requesting the access log, she said to her county colleague. Today's, before the business reset. Full query record on patient Holt's EMR from time of culture result entry. Her colleague left the room. Grant arrived 20 minutes later. He came in with Denton and with the particular quality of someone who had been told what was happening and had not taken the news well. He looked at Forsyth. He looked at Nora. His face did something complicated.
Ms. Voss, he said, I was not informed you would be part of this. Ms. Voss is providing clinical history on an active public health investigation, Forsyth said, without looking up from her laptop. She stays. She's under an HR review.
Mr. Grant. Forsyth looked up. Her voice was not raised. It didn't need to be. I'm conducting a communicable disease investigation under Colorado Statute 25-1-122 that supersedes your HR timeline. If that's unclear, my office can provide a written citation within the hour. Grant closed his mouth. Denton, who had been watching the room with the legal assistant's instinct for reading where weight was distributed, took a half step back from Grant. It was a small movement. It was not a small signal. The access log came back at 9:17. Forsyth read it, passed it to the federal representative, passed it to Nora. Raymond Holt's EMR had been accessed at 4:29, 9 minutes after the culture result entered the system. The query had been run by a user account registered to the hospital's Administrative Operations Division. The account holder was Gerald Grant. The room was quiet for a moment, with the particular quality of a room in which something has just become irreversible. Grant looked at the paper in Nora's hands. He looked at Forsyth. He looked at Denton, who was no longer standing beside him but had moved almost imperceptibly to a position that was technically neutral. I have administrative oversight of all patient records, Grant said. I access them regularly. At 4:29 p.m., 9 minutes after a rare tropical pathogen was identified in a patient's blood culture, Forsyth said, before the lab had completed its internal notification chain, before the attending physician had been reached. She looked at him. What was your clinical reason for accessing that record at that specific moment? Grant said nothing. The DOD General Counsel's office called this hospital at 5:11 p.m., Forsyth said. We've confirmed that timeline with their records office this morning. She closed her laptop. 42 minutes after you accessed the record. The silence was not comfortable for anyone in it, but it was considerably more uncomfortable for some than others. Denton spoke quietly to the legal assistant in the corner, who had stopped typing and was looking at nothing in particular. Nora set the access log down on the table. She looked at Grant, who had the color of a man whose internal architecture had just lost a critical support. She had known this moment was possible, had built toward it, through a night without sleep and a morning of careful sequencing. But knowing it was possible and being in it were different things. She had expected to feel something clean, satisfaction, maybe, or the particular relief of a thing resolved. She felt tired, and she felt the weight of Walsh and Breckenridge, whose names were at the center of all of this, and whose deaths were not going to be undone by an access log or an HR review or a public health investigation, no matter how thorough. But the record was going to be different now. The shape of what had happened in those grid sectors in Kandahar in 2009 was going to exist in a document that couldn't be reclassified. Holt was going to know the truth about the order he'd been carrying guilt over for 15 years. And Raymond Holt, recovering in ICU Bay 6 with a 15-year-old infection finally being treated correctly, had called Pruitt last night, and Pruitt had driven 3 hours. And somewhere in the hospital right now, a retired colonel and his oldest friend were sitting together with information that had been kept from them for a very long time. She was thinking about that when Forsyth's colleague re-entered the room. He set a second document on the table. Forsyth read it. Her expression changed by a fraction of a degree, which on her face was the equivalent of a significant shift. She looked at Nora. "There's something else," she said carefully. Nora looked at the document. It was a secondary access log. Not from Holt's EMR, but from the hospital's veteran patient registry. A query run 6 weeks ago, the same user account. Grant had pulled the full veteran patient registry 6 weeks ago and cross-referenced it with a specific deployment period. Kandahar province, 2001 through 2011. Raymond Holt's name had appeared in the results. And 7 days later, Holt had been admitted to Callaway Veterans Medical Center with a septic presentation that the initial intake team had classified as community acquired. Nora looked at the date of the registry query, looked at the date of admission, did the math that the sequence demanded. 6 weeks ago, Grant had searched for veterans from Kandahar, had found Holt, and 7 days later, Holt had come through the ER door. She looked up from the document. The room was waiting. Nobody in that room said anything for a long moment. The document sat on the table between them, 2 pages, clean formatting, the kind of bureaucratic plainness that made devastating things look ordinary. A date, a query string, a list of returned names, and at the top of that list, in the unremarkable font of a hospital database, Raymond Holt. Forsyth was the first to move. She picked up the document, read it again from the top, set it back down. "Mr. Grant," she said, "I'm going to ask you a direct question, and I want you to think carefully before you answer it." She looked at him over her glasses with the particular quality of someone who already knew the answer and was giving the other person the opportunity to not make it worse. "Why did you query the veteran patient registry by deployment region 6 weeks ago?" Grant looked at the document, then at Denton, then at a point somewhere between the two that was effectively nowhere. "I run administrative audits on patient population data regularly," he said. "It's standard oversight. A query filtered specifically to Kandahar province, 2001 through 2011. We have grant reporting requirements for veteran-specific populations. Mr. Grant," Forsyth's voice didn't harden exactly. It clarified. "I'm going to be transparent with you about where this investigation is going, because I think you're in a position where the next 20 minutes will matter significantly to your future. The access log you generated on Colonel Holt's EMR this afternoon has been transmitted to the Department of Justice Public Health Division as part of this reportable disease investigation. That transmission happened automatically. It's a statutory requirement when a federal communicable disease protocol is triggered and a potential notification chain irregularity is flagged." She paused. "What I'm asking you about now is separate from that. This registry query is something you can explain or choose not to explain. But I want you to understand that not explaining it is also a choice with consequences." Denton put his hand on the table in a gesture that looked like he was steadying himself. "Gerald," he said quietly, using Grant's first name for the first time, which changed the temperature of the room. "I need you to not say anything else right now." Grant looked at him. "Not another word," Denton said. The silence that followed was the kind that meant something had ended. Forsyth made a note on her laptop. Her county colleague was already on his phone in the corner, speaking in a low, efficient voice that suggested the machinery of a formal investigation had graduated from preliminary to something with considerably more teeth. The federal representative who had not been introduced was writing something on a yellow legal pad with the unhurried attention of someone who had been in rooms like this before and knew exactly how they proceeded. Nora sat with her hands flat on the table and watched Gerald Grant's face do something she had not seen it do in 3 years of working under him. It collapsed. Not dramatically, not tears, not any of the operatic versions of a man undone. Just a quiet structural failure, the kind that happened when someone had been maintaining a position for a very long time and the effort of maintaining it had finally exceeded the resources available. He looked older suddenly. He looked tired. She had not expected to feel anything when this moment arrived. She had spent 3 years watching him rearrange nurses instead of fixing problems, smooth complaints instead of addressing the conduct that generated them, use the language of patient care as a vehicle for protecting the things that had nothing to do with patient care. She had expected to feel the clean, uncomplicated satisfaction of a balance being restored. Instead, she felt something more complicated. Not pity, exactly. More like the recognition that people who ended up here, in a conference room with federal investigators and a public health official and an access log on the table, had usually made so many choices along the way that no single moment was really the cause. Grant had queried that registry for a reason she still didn't fully understand, and had contacted DOD General Counsel for reasons she'd have to wait to understand, and none of it had started in a database query 6 weeks ago. It had started somewhere earlier and quieter, in whatever part of him had decided that the machinery of an institution was something to be managed around rather than operated with integrity. She didn't say any of that. She picked up her badge and stood up. Forsyth looked at her. "I'm going to the ICU," Nora said. "Holt needs to know the shape of what's happened. Not the investigation. That'll be explained by people with the authority to explain it. But the clinical picture, the exposure timeline, what it means for his treatment going forward." She paused. "Is there a clinical reason I shouldn't be at that bedside?" Forsyth looked at her for a moment, then at the document on the table, then at Grant, who was sitting very still and not looking at anything. "I have no clinical objection," she said. "The hospital's HR review is an internal matter." Nora looked at Denton. Denton said nothing. She left. The ICU was quiet at that hour, in the way it got quiet mid-morning, between the early rounds and the noon activity. The monitors running, the staff at their stations, the particular sustained focus of a unit that didn't have a rest state, just different levels of intensity. Pruitt was outside Base 6. He was exactly what she'd expected from the phone call. 60-something, built with the solidity of someone who had done physical work for decades and carried it into age, civilian clothes that fit the same way Whitfield's did. He'd driven through the night, and it showed, but it showed in the particular way it showed on people who were accustomed to functioning through it rather than being defeated by it. He looked at her when she came through the double doors, and his expression said he'd been told who she was and had formed his own assessment, which he was now revising against the in-person version. "He's awake," Pruitt said. "Pressure's better than yesterday." "I know. I checked the overnight notes." She stopped in front of him. "How did he take it? What you told him?" Pruitt looked at the bay door. "You know how he took it, the same way he'd have taken a direct hit on the FOB. First he went completely still. Then he asked 3 questions. Then he asked me to leave so he could think." "Did you leave?" "No." A pause. "He told me to leave. I sat down. He let it go after the second time because he knows I've never left when I was supposed to." Something moved across the older man's face. Not quite humor, but adjacent to it. 12 years in the same unit will do that." She nodded, looked at the bay door. "I told him what you said," Pruitt said, "about Walsh and Breckenridge, about what they did and what it cost and what it stopped." "How?" "He didn't cry, if that's what you're asking. He's not built for it." Pruitt looked at her steadily. "But I've known that man for 32 years, and I watched something leave him last night. Something he's been dragging around since 2009 and probably couldn't have named out loud. Whatever it was, it left." He paused. "That's on you. Whatever you did in that bay 2 days ago." I told him the truth. "That's what I said." She went in. Holt was propped at the familiar 45-degree angle, the oxygen cannula in place, the monitors running their quiet accounting above his head. He looked better than yesterday. Not well, nowhere near well, but better in the specific way that happened when the right antibiotic had been running for long enough to begin changing the balance of a fight that a body had been losing alone for too long. He looked at her when she came in. "Pruitt said you were coming," he said. "I told him I would." She pulled the chair close and sat. "How do you feel?" "Like someone's been running a construction project inside my chest for 2 weeks." He looked at the monitor briefly. "But the doctor said the numbers are moving." "They are. The ceftazidime is doing what it needs to do. The The cardiac inflammation is responding. She paused. It's going to be a long treatment course. Weeks of IV antibiotics, then months of oral maintenance. You'll need follow-up imaging, repeat cultures, specialist involvement for at least a year. I know, Osei explained it. I'm not telling you things you don't know, she said. I'm telling you I'll be following your case. He looked at her. Grant has other concerns right now. Something shifted in his expression. He waited. The investigation this morning produced information, she said. I can't tell you details because the specifics are in the hands of people with the proper authority. But your case is no longer a standard HR complaint against a floor nurse. She looked at him directly. The query that Grant ran 6 weeks ago, the one that pulled your name from the veteran registry, the investigators are trying to establish what he did with that information and why. There are questions about the timeline of your admission. Holt was very still. He knew I was coming in, he said slowly. It was not a question. He was building the sequence the same way she had, the same way anyone who'd spent time in operational environments built sequences, looking for the logic that connected the pieces. The investigation will determine what he knew and when. But you think he did? She looked at him. I think the registry query and your admission date are 7 days apart. I think the DoD General Counsel was notified of your culture result 42 minutes after Grant accessed your record. And I think someone wanted the conversation about Kandahar to be controlled by people whose interest was not your well-being. She paused. That's what I think. What I know is that the investigators are competent and thorough, and that the documentation exists. He was quiet for a long time, long enough that the monitor cycled through 2 complete readings. Why would he... He stopped, started again. What did he stand to gain? I don't know that yet. Possibly nothing personal. Possibly he was a contact for someone else. Someone in the DoD chain who was trying to manage the exposure liability before a melioidosis case, and a Kandahar veteran could create questions about the 2009 USA MRIID assessment. She thought about the shape of it. When institutions try to protect themselves from accountability, they don't always need the people doing it to understand the full picture. They just need someone willing to do small things and not ask why. Holt looked at the ceiling, at the monitors, at his own hands resting on the blanket. Walsh was 23, he said. Yes. I've said that number to myself approximately 10,000 times in the last 15 years. His voice was flat and even, which she'd come to understand was not the absence of feeling, but its most controlled expression. I've gone over that order, the routing, whether I should have pulled them back, whether I missed something in the intelligence picture. The intelligence picture had a gap that wasn't yours to know about. I know that now. He looked at her. Knowing it doesn't fix 15 years. No, she said, it doesn't. She didn't offer him anything else on that. She'd learned in years of sitting with people in the worst hours of their lives that the impulse to repair the irreparable with words was well-intentioned and almost always wrong. You couldn't fix 15 years. You could only change what the next 15 looked like. What happens now, he said. You get better. The investigators do their job. The county epidemiologist is going to contact veterans from your task force deployment. There may be others who were exposed and haven't been identified yet. You'll be asked to provide a detailed exposure history, which will be used to help locate them. She looked at him. And at some point, when you're well enough, there will be a formal process for what happened to Walsh and Breckenridge and the other men. A record that says clearly what the USA MRIID assessment showed and what command chose not to share. Will anyone be accountable? She thought about that honestly. I don't know. The people who made those decisions in 2009 are scattered, retired, separated, in some cases gone. The institutional accountability is more likely than individual accountability. But the record will exist, and the record matters. She paused. It matters to the men. It matters to their families. He nodded slowly. Pruitt tells me, he said, that you never told him your service record either. Not when he called. Not when you talked last night. It didn't come up. It didn't come up, he repeated. And there was something in the repetition that wasn't quite disbelief, more like a recognition being processed. You've been in this hospital for 3 years and nobody knew. Nobody needed to know. And when Grant was filing papers against you,
It still didn't need to be the reason I stayed on your case. She met his eyes. The reason I stayed was the pressure trend and the culture result in the fact that I understood your clinical picture better than anyone else on that floor. That's the reason. The service record is mine. It's not a credential I use to justify my judgment. My judgment justifies my judgment. He looked at her for a long moment. Staff Sergeant, he said. Not like a reminder, like he was placing it where it belonged in the right category. Long time ago, she said, not to me. He straightened slightly in the bed, the minimal version of a man who would have sat at attention if his body had permitted it. I'd like to make a statement to whoever is running the HR process, to the board, to whoever needs to hear it. I want it on record what you did in this unit, starting from the first morning. The situation is already moving, she said. The investigation changes the HR picture regardless of, I know that. I'm not doing it to change the HR picture. He looked at her steadily. I'm doing it because it's accurate, and because the hospital's record should reflect what actually happened here. She didn't argue with him. Tit. The formal meeting of the hospital board took place 9 days after Raymond Holt's culture result came back. By then, several things had happened in the sequence that investigations produce when they are conducted by people who understand that thoroughness is not a courtesy, but a requirement. Gerald Grant had been placed on administrative leave within 24 hours of the conference room meeting. Not terminated yet, because the formal process required its own timeline, but removed from any operational role while the DOJ Public Health Division and the County Communicable Disease Office completed their joint review. Denton had submitted a letter to the board clarifying that his role had been to manage the hospital's legal exposure, and that he had not, at any point, been aware of the nature of Grant's registry query prior to the access log disclosure, which was either true or the most carefully worded piece of legal protection she had ever seen, and possibly both. The HR review against Nora was closed. It was closed in a single-page document that did not use the word apology anywhere, because institutions rarely did, but which contained the phrase, findings do not support the basis for disciplinary action, and the further phrase, employees' conduct throughout the period in question was consistent with clinical standards and professional obligations. She read it once, signed the acknowledgement form, and filed it in the folder where she kept documents she might need later. Webb called her that evening. Board meeting Thursday, he said. They're going to want you there. What for? They want to hear from you directly, about the case, about the sequence. A pause. And because there's a proposal on the table about the trauma education program, and they'd like your input. She said she'd be there. Og. The boardroom was on the executive floor, which she had been to exactly twice in 3 years, once for an onboarding orientation, and once because a family had filed a compliment about a different nurse, and somehow she'd been included in the notification list by accident. It was a different part of the building, the part that had artwork on the walls and carpet instead of linoleum, and the particular quietness of a space that didn't deal with emergencies. There were 14 people around the table. She recognized the chief medical officer, the CNO, 2 department heads, and Forsyth, who was there in her capacity as the county investigator of record. The rest were board members, a mix of ages and backgrounds, the kind of group that got assembled to govern something complicated. Raymond Holt was also there. He was in a wheelchair, which he had agreed to with what Pruitt later described as approximately 45 minutes of objection, and he was dressed in civilian clothes rather than a hospital gown, for the first time since she'd met him, which made him look both more and less like the man she'd come to know. More, because the clothes fit someone who had once commanded a task force. Less, because the gown had contained a specific kind of vulnerability that she'd watched him slowly stop being afraid of. Pruitt was behind the wheelchair, having apparently decided that his role in this situation was to be physically present at all times until further notice. Nora sat where she was directed, not at the head of the table, not at the foot, somewhere on the side that put her adjacent to Forsyth. And across from a board member she didn't know who had the attentive stillness of someone who'd read everything before arriving. The board chair, a woman in her 60s named Patricia Sue, opened without preamble. She had the bearing of someone who had been managing difficult situations for long enough to have stopped finding them theatrical. I want to be direct about the purpose of this meeting, Sue said. We are not here to conduct the investigation. That process is ongoing, and we will receive formal reports through the appropriate channels.
We are here because the events of the past 2 weeks have raised questions about this hospital's operational culture that the board has an obligation to address publicly and specifically. She paused. We are also here because several people in this room are owed a clear statement from this institution, and I intend to provide it. She looked at Nora. Nurse Voss, the board has reviewed the HR documentation from the past week, including the original complaint, the management notice issued by Mr. Grant, and the subsequent investigation findings. We have also reviewed the rapid response documentation, Dr. Ose's clinical notes, and the public health investigation records as they relate to your conduct during Colonel Holt's admission. She paused. The board's finding is unambiguous. Your clinical judgment throughout this case was sound. Your conduct was professional, and the administrative action taken against you was not supported by clinical evidence and was, in the board's assessment, an improper use of supervisory authority. She paused again. I want to say that in this room, to your face, because a letter in a file is not the same thing as saying it out loud. The room was quiet. Nora said, "Thank you." It was the only thing she had. She'd prepared more, but it turned out she didn't need it, because Sue had said the thing she'd most needed to hear and said it in the right way, which was plainly and without softening, and all the words she'd arranged on the drive over became unnecessary. Holt spoke next. He hadn't been asked to speak. It became clear quickly that he had simply decided he was going to, which was consistent with everything she knew about him. Pruitt made a small resigned gesture behind the wheelchair that said he'd been informed of this plan and had offered the same resistance he'd offered to the wheelchair, with the same result. I came into this hospital angry, Holt said. His voice was steadier than it had been in the ICU. Not fully recovered, not by a long way, but the particular quality of a man who had chosen to be present rather than diminished. I was sick, and I didn't want to admit it, and I took it out on the first people I encountered. That's on me. He looked around the table, not performing anything, just making contact. What's not on me is what happened after. A nurse who had every reason to step back from a hostile patient stayed on that case because she understood that the case needed her, and the administrative response to that was to try to remove her. He paused. I want the board to understand that the care I received in this hospital's ICU from Dr. Ose and her team was excellent. I also want you to understand that the reason I am alive to sit in this room, with some medical opinion to back that up, has a significant amount to do with the nurse who was being formally documented against while she was keeping me from coding. He said it without heat, just as information, delivered by someone whose business had always been information under pressure. I thought that should be in the room. Nobody spoke for a moment. It is, Sue said. She moved to the next item on the agenda, which was the question of the hospital's response to the public health investigation findings and the DOJ review, the clinical protocol review, the veteran patient registry access controls. Forsyth presented her recommendations, which were specific and structural, not about individual blame, but about the systems that had allowed individual failure to go undetected. She spoke for 20 minutes, and the board listened with the focused attention of people who understood they were being told what to fix and were prepared to fix it. Then Sue said, "There's a proposal before the board regarding the hospital's trauma education program. I'd like to hear from Nurse Voss directly." Nora had been told about the proposal the day before by Webb, who had been characteristically brief about it. They want to expand the trauma training curriculum and rename the program. Your input is requested on the clinical components. She'd assumed it was a consulting role, a committee seat, something like that. She looked at Sue. What specifically is the board proposing? The expansion of the trauma education program to include a battlefield triage and emergency resource-limited medicine module, content that currently doesn't exist in our curriculum. The board would like to hire a clinical director for that module. Sue looked at her. We're asking if you'd be willing to take that role, in addition to your floor responsibilities, at least initially. Nora sat with that. That would require building the curriculum from scratch, she said. Yes. And coordinating with the military medical programs for validation. We're aware. It's a significant amount of work outside the scope of floor nursing. We're aware of that too. Sue's expression had the slight patience of someone waiting to see if the objections were substantive or reflexive. Is that a no? Nora thought about it honestly. She thought about the 14 hours in Kandahar. She thought about the things she'd carried from that time. Not just the names, but the knowledge. The specific, hard-won, procedural knowledge of what worked under conditions that no classroom had prepared her for. She'd kept it quiet for 6 years, not because she was ashamed of it, but because she'd never seen a context where it was the right tool for the moment. She was looking at the context now. "It's a yes," she said, "with conditions on the curriculum development timeline and staffing support." Sue nodded. "We'll negotiate the specifics." Grant's termination was finalized 2 weeks after the board meeting. It was not announced dramatically. These things rarely were. A memo to department heads, a note in the system, the standard language about restructuring and transition. But the details, which spread through the hospital the way details always spread through places where people worked closely together and paid attention, were less standard. The DOJ review had found that Grant had been in contact with a retired DoD civilian contractor who had flagged Holt's potential melioidosis risk to him through a private channel. A contractor who had been employed years before by the same Defense Logistics Office that had overseen the 2009 Kandahar operation, and who had, the investigators believed, been managing the exposure liability question quietly for years. Grant had not been part of that original chain. But he'd been a useful point of contact, and he'd been willing to be useful, and that willingness had cost him everything he'd spent 3 years building. The contractor was under federal review. The specific questions about who in the 2009 command chain had known about the USA MRI-ID assessment, and what they'd done with that knowledge, were moving through a process that would take longer than any of them wanted, but that was, at least, moving. The families of Walsh and Breckenridge had been notified by a formal military liaison. Nora didn't know what those conversations had looked like. She hoped someone in that chain understood the difference between a notification and an acknowledgement. 3 other veterans from the 2009 task force were identified through the epidemiological follow-up as having unresolved chronic infections consistent with latent melioidosis. 2 were treated and responded. 1 had already been dealing with it for years under a different diagnosis, and wept, according to Forsyth's colleague who'd made the contact, not from distress, but from the specific relief of being told that the thing that had been happening to him was real and had a name and could be treated. Holt was discharged on a Tuesday morning in early November. The sun was out, which was the kind of detail that shouldn't matter but did, because November in Colorado could go either way, and the light that morning was genuine, thin and cold and completely clear. Nora was at the entrance with Pruitt when they brought Holt down. He'd refused the wheelchair for the actual departure, which the discharge nurse had documented with the professional patience of someone who had learned to pick battles, and he walked out under his own power with the particular gait of a man who had just spent 2 weeks in a hospital bed and was reminding his body who was in charge. He looked better. Not young. Nothing about this had made him look young. But better in the specific way that happened when the right treatment had been running for the right amount of time and the body had been given what it needed to do the work it was designed to do. The infection was in the eradication phase. He had 6 months of oral antibiotics ahead of him, follow-up imaging, quarterly cultures. Osei had given him a 17-page discharge packet that he'd folded in half without reading and put in his jacket pocket, and she'd made Pruitt promise to make him read it, which Pruitt had done with the expression of a man who had made promises about Holt before and understood their limits. He stopped in front of her. "You look like you slept," he said. "I did, actually. First time in about 10 days. "Good." He looked at her with the directness that had been there since the first morning, the look that didn't perform anything. "The curriculum. How's that coming?" "I'm 3 weeks in. I have the battlefield triage module drafted, and I'm working on the resource-limited emergency care section." She paused. "I keep arguing with myself about the right case studies. Use real ones. Most of the relevant ones are classified. Some of them aren't." He looked at her steadily. "I know some people who might be willing to sit down with you. Men and women who were there for things that ended up in declassified after-action reports. Who know what it actually looked like." A pause. If that would help? She thought about that. About a curriculum that had actually been built by people who had been there, who knew what the textbook versions left out, who understood the gap between what training showed you and what happened when you were in it. "It would help," she said. He nodded once.
The formal version of something that was not entirely formal. Thank you, he said. Not the social version, the one that meant something specific. You already said that. I'm saying it again.
She let it stand. Pruitt put his hand briefly on her shoulder as he moved past, a quick, solid contact that said more than he would have been comfortable saying out loud. And then he was steering Holt toward the car with the efficiency of someone who had been managing this man's stubbornness for 32 years and had developed reliable methods. She watched them go. The parking lot was ordinary the way parking lots were ordinary. Cars, light, the sound of the city in the middle distance. Nothing cinematic about it. Just a man walking to a car on a cold Tuesday morning, moving better than he had 2 weeks ago, alive in the specific and uncomplicated sense of the word. She stood there until the car was gone. Then she went back inside. She thought about it later, not that day, but in the weeks after, when the curriculum was taking shape and the board proposal was moving through its proper channels, and the things that had been broken were being repaired with the imperfect, incremental work that repair actually required. She thought about what it had cost to stay quiet. Not about her service, she didn't regret the privacy, it had been hers to keep, but about the judgment she'd applied every morning for 6 years, the clinical instincts and the hard-won knowledge, working in a space where no one knew where it came from, and some people therefore assumed it came from nowhere in particular. She thought about the water pitcher on the floor of room 412 and a furious, sick man pointing at her like she was an obstacle. She thought about the conference room and Grant's folder and the word rapport being used as a weapon. She thought about sitting in the parking garage at 11 p.m. with a drive full of information that was going to change the shape of things, wondering whether to make the call. She thought about what Holt had said in the ICU the night she'd told him the truth about Walsh and Breckenridge. You've dealt with this before, being dismissed by people who don't actually know what you are. She had. She'd dealt with it for 3 years in this building, and for years before that in buildings and organizations and situations where the conclusion people reached about her, based on what they could see, was consistently smaller than the truth. She'd learned to work around it, to stay quiet, to let the outcomes speak and absorb the implication that the outcomes were somehow accidental. What she understood now, or more precisely, what she'd always understood but had been unable to make institutional, was that staying quiet had never actually protected anyone. It had protected the comfortable assumption. It had allowed the people who dismissed her to remain undisturbed in their dismissal. And the cost of that over time was not just to her. It was to everyone whose care depended on her being recognized as what she was. You couldn't help people from a position of deliberate invisibility. Not fully. Not in the way that actually counted. She was done being invisible. That didn't mean being loud about it. It didn't mean making her service record a badge she wore. It meant building a curriculum that took the knowledge she'd spent 15 years carrying and put it into the hands of the next generation of nurses who would be the ones in the room when it mattered. It meant making a case to Forsyth's colleague about the veteran follow-up protocol and making it in her own name, backed by her own expertise, without apologizing for either. It meant walking into a boardroom and saying yes with the quiet authority of someone who had earned the right to say it without explanation. The curriculum was named for what it taught, not for her. She'd pushed back on the board's initial proposal to attach her name to the program. It had felt wrong, not from modesty, but from the conviction that the program's value should be in its content and not in the story of how it came to exist. The board had disagreed with her, and they'd negotiated, and they'd landed somewhere in between. The program was called the Advanced Clinical Response Initiative, and in the documentation, the formal description distributed to the nursing school partners and the military medical liaisons who'd agreed to consult, there was a single paragraph in the program overview that described its origins. It did not use her rank. It used her name, just her name and a plain statement of what she'd done and why it mattered. It was the kind of paragraph that would be read by new nurses on their first day of the program and then forgotten by everyone except the ones it landed on in the right way, at the right moment, when they needed to understand something that couldn't be explained in a textbook, which was exactly how she'd wanted it. In February she got a letter, not an email, a letter, handwritten, on plain paper with the Denton Falls return address. The handwriting was the kind that had been taught in a specific era, careful, upright, slightly formal. Voss, 6 months out. Numbers are where they should be, according to OC. Oral course ends in April. Pruitt says I complain about it less than expected. He is wrong about this. I've been speaking with 3 men from the task force who agreed to consult on your curriculum: Hargrove, Mendez, and a woman named Tillman who was an 18D with the attached SF element. They know their material and they're willing. Contact information attached. Walsh had a sister in Boise. I found her. We've talked twice, it's not easy. But I think it's the right thing, and I think you'd agree. Thank you for not letting them move you. Holt. She read it at the kitchen table on a Thursday morning before her shift. Read it again, folded it and set it next to her coffee cup and sat with it for a while. Outside, it was snowing, the thick, quiet kind that came in February in Colorado, the kind that changed the sound of everything and made the city briefly soft. She could hear almost nothing through the window, just the particular silence that snow made, and underneath it, the ordinary hum of a morning doing what mornings did. She thought about Walsh's sister in Boise, about what it must have been to receive a call after 15 years from the colonel who had commanded the operation where her brother died, about what Holt had said in his own voice and what he hadn't been able to say, and the particular cost of both. She thought about the things that didn't get easier, about how the idea that time resolved everything was, in her experience, mostly wrong. Time changed the shape of things. It didn't dissolve them. Walsh was still 23. Breckenridge was still 26. The weight of that was not going to become light simply because the record had been corrected and the investigation had concluded and the right people had been held to the right account. But the record was different now, and that mattered. Not as a replacement for what had been lost, nothing replaced it, but as a fact in the world that had not existed before. A document that said, this is what happened, this is what they did, this is what it cost, this is who knew and when they knew it. She folded the letter back into its envelope. She thought about what she would write back. She thought about Hargrove and Mendez and Tillman, who had agreed to sit down and talk about the things that curricula usually left out. She thought about the nurses who would go through the program in the spring, the ones who were 2 years out of school and had already figured out that what they'd been taught was a foundation and not a ceiling, who were hungry for the next level of the thing, who were going to be in rooms someday where everything depended on what they knew. She thought about what it meant to carry knowledge for a long time in silence, and what it meant to finally put it down somewhere it could be used. She picked up her coffee, looked out the window at the snow. There was a version of this story where she had stepped back the first morning, where she had let the water pitcher and the insults and grants folder accomplish what they were designed to accomplish, and had taken her 5 remaining patients and finished her shift and gone home and made no calls and stayed quiet. She had stood in that version of the morning, briefly, in the 30 seconds between the heart monitor alarm and the moment she decided to walk back to the side of the bed. She was glad she had moved, not because it had been easy or clean, or because the outcome had been tidy. None of it had been any of those things. She had stood in a parking garage at 11 p.m. with a USB drive and a question she couldn't fully answer yet, and she had sat in a conference room with 2 men trying to dismantle the record of her own judgment, and she had spent 10 days not sleeping enough and eating poorly and running on the particular fuel of people who had decided that a thing mattered and were going to see it through regardless of the cost. It had cost her. She wouldn't pretend otherwise. But Walsh's sister in Boise had received a phone call. 3 veterans with unresolved chronic infections now had a diagnosis and a treatment. An access log sat in a federal record that documented exactly what had been done and by whom. And in the spring, a cohort of nurses would learn things in a classroom that she had learned in a fob, in Kandahar, taught by someone who understood that knowledge was not meant to be carried alone. You didn't stay in the room for the thanks. You stayed because the alternative was leaving someone there alone when they needed not to be alone. Because the work was the work, regardless of who was watching or what they assumed about you or how loud they were about those assumptions. You stayed because you could, and because in the moment when it mattered most, when the monitors alarmed and the room filled with people doing everything right, staying was the only thing that made sense. She finished her coffee, went to work.